हाँ सर हेलो इधर कुछ वो कनेक्टेड से है ना, वो कनेक्टेड कर दीजिए वो स्पीकर। हाँ अच्छा कनेक्टेड आज के दिन के लिए ये होस्ट रहेंगे। यही वाला तो ऐसे ही कनेक्ट करने के लिए। कंप्यूटर को हेलो 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 आवाज आ और एक्सेप्ट न्यूज़ पे रहता है हाँ हेलो गुड मॉर्निंग सर
Good morning, very good morning.
वेलकम वेलकम सर हेलो डॉक्टर परिक
Yes, sir. Good morning.
जय जिनेंद्र
Jai Jinendra.
This corona has made all mandatory mask, so it remains Jain religion which is following wearing mask since long.
Yes.
We have seen Jain saints moving across the
Yes.
many places wearing mask mandatory.
Yes. Lifetime they are wearing mask.
All is well.
All is well. Yesterday had some problem, but now she is well. I mean, reports are almost.
She means who?
Mrs. Parik.
Her main pain you are not resolving.
Pardon, sir?
Her main pain is not yet resolved, no?
That issue is not resolved because yesterday she had a pain. So again I went to the surgeon. He told ki still it will have some time to resolve, and then we can plan for cholecystectomy, not at present.
Her main pain is not cholecystectomy and other things. You are not giving her relief now. Bring somebody, his daughter, as daughter-in-law,
Yes.
will be resolved.
Okay. It is in the process, final stage. Within a couple of days, I mean, you will come to know.
Wait till that days. No need of cholecystectomy.
Yes. Sure.
She is expressing pain indirectly that if you don't now expedite the process, every day she will express pain.
No, it is true, but this whole process, it is not in my hand or not in her hand.
Yes. We are very happy that it is now in final stage. All are well in department, college. All are well in department and college and all.
All are well.
Okay.
All are well. We are only, very limited number of staff. So
who is Dr. Mala, Dr. Kelawala, and
Dr. Mala is pursuing his PhD. He is doing fine. Parmar is at TVCC. Dr. Hadia, after retirement of Dr. D.M. Patel, Hadia has joined as a head TVCC in charge or head. And rest of the faculty, day by day it is depleting. After Dr. Noriel, this year we have few more faculties got retired. Dr. Balsare, then this time D.M. Patel. After that, we had two more faculties. Dhami, Dr. Dami has asked for the VRS. He has requested the universities that he should be given VRS.
આણંદમાં અશ્વમેઘ યજ્ઞ કરાવો અને ઘોડાને છૂટો મૂકો, જ્યાં જાય ત્યાંનો સ્ટાફ લઈ લ્યો.
ये बात साची, ये बात साची.
એક ઘોડાને છૂટો કરવાની જરૂર છે, ચારે કોલેજ ફ્લરિશ થઈ જાય.
100%.
ઘોડાની પસંદગી તમારી.
અરે વાહ, ચોક્કસ.
એટલે ત્યાં બધા ફેકલ્ટી ભેગા થઈ ફેકલ્ટી ક્લબમાં અશ્વમેઘ યજ્ઞ કરાવો અને એક ઘોડો પસંદ કરીને ગુજરાતમાં છૂટો મૂકી દો, જેટલા પ્રદેશમાં જાય એનો સ્ટાફ તમારો.
બરોબર છે. એવું કરવું પડે એવી પરિસ્થિતિ જ છે. અશ્વમેઘ યજ્ઞની પરિસ્થિતિ આવી જ ગઈ છે અને અશ્વમેઘ નહીં થાય તો પછી જે તે દિવસે ડિપાર્ટમેન્ટમાં મોટો યજ્ઞ થઈ જશે એવું લાગે છે હવે તો.
Please, Chair.
So, very good morning to all of you. In this special occasion of day 3rd of this vocational training on advanced diagnostic technique in livestock and pets, organized by Department of Veterinary Surgery and Radiology, College of Veterinary Science and Age in Junagadh. So, the respected principal and deans, Dr. P.S. Stark sir, Organizing Secretary Dr. H.S. Paleka, and Head of Department of Veterinary Surgery, the Chairman for today's session, myself, Dr. Vishnu Kumar, Associate Professor and Head Veterinary Anatomy, Co-Chairman Dr. A. Wag, he is Associate Professor and Head Department of Veterinary Medicine, the reporter Dr. A.D. Verma, Assistant Professor from Department of Veterinary Animal Genetics and Breeding, Co-Organizing Secretary Dr. A.K. Sharma, the convener of Technical Committee Dr. A. Garksav, and all the students and all the participants who have joined this training. So for today, there are 2 lectures in the forenoon session. One by Dr. P.V. Parikh sir. The topic is veterinary endoscopy and overview, followed by Dr. S.K. Jirwal. The topic is advances in diagnosis of ophthalmic affections in dogs. And in afternoon session, the demonstration will be given by Dr. S.K. Jirwal on surgical management of cataract in dogs. So, Dr. S.B. Parikh sir have the first lecture.
Dr. P.V. Parikh.
Sorry, Dr. P.V. Parikh sir have the first lecture. Dr. P.V. Parikh sir have 33 years of experience in the field of veterinary surgery and radiology on different aspects. So, sir have definitely have the vast experience, and all the audience have definitely give the whatever the experience in the veterinary surgery and radiology. So, sir have given their some of the brief experiences and the achievements. So, I request Dr. A.D. Verma to read the achievements and the this resume of the Dr. P.V. Parikh sir.
Wishing everyone a very good morning. Dr. P.V. Parikh, born on 26th of June 1964 at Vadali district, Sabarkantha, Gujarat, completed graduation from College of Veterinary Science and Animal Husbandry at Srinagar, Gujarat Agriculture University in 1986 and obtained his master's degree from the same institute in the year 1989. He completed his doctoral studies with honors from GVPU, AT and Valnagar in year 1995. He has contributed immensely in the field of veterinary surgery and radiology as academician, researcher, planner, as well as extension worker. He was awarded with Vice Chancellor's Gold Medal and Best Student Award for being adjudged the best outgoing undergraduate student, Dr. N.D. Patel Award for securing highest OGPA in the subject of animal genetics and breeding. He was also recipient of ICAR, JRF, and SRF during MPSc and PhD degree, respectively. He was awarded A.K. Bhargava Memorial Gold Medal for Best Research Paper published in ISPS Journal in the year 2004. Hari Om Ashram Credit Shri Bhai Kaka Inter University Smarak Trust Award for the year 1997-1998 for the best research paper. He was awarded as best teacher in higher agricultural education amongst all faculties of AAU in the years 2017-18 by ICAR. He was also awarded Professor J.P. Trivedi Award for Ophthalmic Research in 2019 by GAS. He was awarded with 5 gold medals and 10 appreciation awards for the paper presentations in various conferences. He has delivered many late papers, expert lectures, keynotes, addresses, etc. in different training programs and symposia. He had served as a veterinary officer for 3 years, assistant professor for 9 years, associate professor for 8 years, professor for 13 years, and presently he is working as professor and head since last 6 years in the Department of Veterinary Surgery and Radiology, College of Veterinary Science and Animal Husbandry, Anand Agriculture University, Anand, Gujarat. Besides the vast exposure and experience in the clinical practice and teaching, Dr. Parikh has guided 42 of MBSc and 4 PhD students till date. He has published more than 100 scientific articles in reputed national and international journals, more than 50 popular articles, 2 booklets, 18 manuals, and 30 presentations in different conferences. He has entered several research projects as PI and co-PI, and also has acted as course director for advanced trainings for veterinary surgery and radiology for field veterinarians. He is known for arranging bird treatment camps in entire Gujarat state during Kite Festival and for organizing various surgical camps for Gaushala and Panjapurs. Looking to his contribution, he was also awarded Fellow of Indian Society for Veterinary Surgery. So it was a brief introduction about respected Dr. Parikh sir. After this, I request you sir for the presentation.
Thank you for. So shall I start?
Yeah, yes, sir.
Yeah.
Thank you for giving my introduction, and at this juncture, I would like to congratulate Dean of the Veterinary College, Junagadh, for arranging a vocational training on recent advances in diagnostic imaging and choosing me as one of the speaker for veterinary endoscopy. Second thing is the Dr. Talekar, who has always been very known for his clinical field exposure, and he is heading the surgery and inviting me for the presentation. At this juncture, I would like to congratulate and thanks the respected chairman and the co-chairman and the report here. Some of the faculties I know, Dr. Wagh, I know he's Professor Medicine there. I think he's also reporting. And some of the faculties, some of them, they are very well known to me, but I cannot recognize their faces. So please pardon me for that, because they all are, my friends and fellow colleagues. So with this, I will going for the presentation of veterinary endoscopy and overview. So if we talk of veterinary field as such, endoscopy or endosurgery, because these two parts are going simultaneously. When we talk of veterinary endoscopy or endoscopy as such, endoscopy is to see inside the body cavities, basically. Scopian is to see, endo means inside. So this is the understanding of the two word endoscopy. But when we talk of endoscopy, naturally, when you see inside the body cavities or a hollow organ by means of a specialized instrument called endoscope, this will give rise to a simultaneous development of the surgical field also. That is a field, what is it known as laparoscopy, where after seeing through endoscope, laparoscopic surgery is being done. So these two fields, endoscopy and endosurgery, both these fields are going or developing together. Now, if you see the historical development of the endoscopy over a period of time, so in 18th century, the development or the endosurgery or endoscopy was in a very primitive phase. The Greek, Roman physicians, they were using various specula for examination of vagina. They were using 4-pronged specula for examination of vagina, and they were using during those times natural light for examination. Now, after that, era has come in the 18th century where the endoscope, where, I mean, in a very primitive phase, wherein the first cystoscope was developed by the scientists. And these cystoscopes, the light illumination was used was a candle. You will surprised to hear that candle can be used for examination of internal organs. So this candle, wax candle, which was beeswax candle, was used for examination of internal organs in the year 1853. Now, in the most of the work, most of the developments of the fibroscope or fibroendoscope or the endoscope has taken place in the 19th century. With the development, if you go through the whole or you scan through the literature, you will find that there are a lot of critics about the history of development. There are a lot of people, they started working on this, but a lot of critics was there at those times. And this field was not developing. Now, the first commercially available endoscope by Karl Stoss was launched in the year 1945. Now, how this changes of illumination of internal organ has taken place. Basically, if I talk of, in short, if I talk of, that is basically how you can see inside with the help of light. So the development has taken place after the invention of bulb by Thomas Alva Edison in the year 1897. When he invented the light bulb, this light bulb was used as a source for illumination, and the better picture of internal structures can be visualized with the help of the endoscope. Later on, during the development process of the light source, again, the development has taken place by invention of a glass rod fibers which carry the image. Means conduction of image can be possible with the help of optical fibers. Then the era came, when these optical fibers, they carry the image, these images, the invention of television has taken place. So the invention of television, where these images, whatever you are getting, either with the help of the optical fibers, can be visualized on the monitor. So this is the development of telescope, endoscope, and the changes which are taken place in the light source. The overall, the picture quality was improving day by day. And the revolution, you can say the revolution has come after the invention of a CCD camera. So this charge coupled device camera, they are basically used at the tip of the endoscope, and this camera, they transmit the images electronically onto the monitor, and you can see the better picture of the the internal organs. This is how the I was talking to, I was scanning through the available literature. Then I got name of one scientist, Kurt Same. You will surprised to know that the Kurt Same was working in the year 1970 somewhere in Yale University as he was developing a laparoscope. So during the initial phase of laparoscope, he was criticized like anything by his colleagues. He was told that you are reckless, you are dangerous. This type of surgeries cannot be taken place in a human being. So that was the word. And during one of his presentation, the society people, they asked to unplug the projector, and people told him, you don't present in this symposia. So this was the time. After that, the Sam worked day and night. He developed, the laparoscopic surgery. He is considered to be a father of laparoscopic surgery. So this is all about the history. It is very fascinating when you go through the literature, history of the endoscope. So you know the laparoscope is minimal invasive surgery, wherein patient will be discharged after this. There is actually visualization of the internal organs. Along with that, has got some therapeutic value also. So you can remove some foreign, you can do biopsy of the some internal organ structures. You can do surgical snare polypectomy and many more things you can do with the help of nowadays. Now, what are the disadvantages? When we talk of veterinary field, the equipment is very costly and the learning curve is always for this procedure, I mean laparoscopic surgery or endoscopic type of work, there is a steep learning curve. So you have to continuously do that kind of work, or you should have the actions with the instrument, understanding of the instruments and its use. Then only you can come out of the learning curve and you can develop the, you can extend the procedure. Now, if you see the endoscopes are two types. One is rigid and flexible endoscope. So these rigid endoscopes, they are endoscope and they are known as telescope also. And they are basically used for evaluation of non-tubular structures. When you want to examine a non-tubular structures, like some cavity which is straight in nature, like rhinoscopy, the nasal passage, you want to examine, you can use telescope. You want to examine some of the, straight passage like cystoscopy, female cystoscopy, where you can use a rigid endoscope. But when the cavity is tortuous, when the cavity like gastrointestinal tract, respiratory tract, male urinary tract, where there is a tract is tortuous and you want to examine inside, then the flexible endoscopes are used. So basically they are of two, the rigid endoscope and flexible endoscope. Again, if you see the flexible endoscopes, they are of two types. One is fibroscope, another is fibroscope, another is video endoscope. Now this is giving, I am giving some primitive information about these scopes because this understanding is required before you venture for purchasing any scope. So this video endoscope, again, this is a best development where in video endoscope, the images are transmitted to a chip which is located in the distal portion of the axis of the endoscope. Whereas in fibroscope, the images are transferred through optical fibers. Let us see. Before telling all these things, I should explain you what are the different parts of the endoscope. So the understanding becomes easier about the, so this is the photograph or the picture of an endoscope, which shows, basically it is comprised of three portions. This portion is known as umbilical cord. This portion is known as umbilical cord. This portion of this is known as handpiece of the endoscope. And this is a tail portion and this is a distal tip. So with this understanding, if you see the scope, in this scopes, from here umbilical cord, the light source is attached. So once the light source is attached, there is here also there is opening for air insufflation, there is opening for suction pump. It is located in the umbilical cord itself, at the umbilicus only, where handpiece, various are means for deflection of this tailpiece. So you want to deflect the tip right side, you can deflect the tip on the left side. You can do with the help of handpiece. You can also make the tip up. You can also make the tip down. That is upright and up down can also be done. Deflection. Along with deflection, there are some valves are also there. And there are some instruments channels which are located on the endoscope. Through these instrument channels, you can pass various instruments like brushes, you can pass snares, you can pass forceps. These forceps come out at distal tip and they helps in maneuver of the internal organs. Now distal tip is, you can see in distal tip there are lenses, there are irrigation nozzles, insufflation nozzles, instrument channels through which instruments and brush and forceps they come out. So this is basically various parts of the flexible endoscope. Now what are the, how fibroscope and videoscope differs? In fibroendoscope, the image carried from a lens at the tip of the endoscope via bundle of fiber optic glass fibers. Whereas in endoscope, for viewing the image, there is a CCD chip located in the distal tip of the endoscope, and this transmits the image electronically to a video monitor via processor. And the image of the video endoscope quality is very good, far superior to that of fibroscope, and therefore carries a greater cost. And the absence of fiber optic bundles ensure that the images will not contain black dots. Now, what is this fibroscopes actually? These fibroscopes, the main advantage of use of fibroscopes, they are less, they are less expensive, and they are available in less than 6 millimeter in diameter. So in veterinary purpose, suppose you want to pass a scope in a cat, or you want to pass a scope in a male dog, then you cannot, because all these video endoscope, they are available, and this video endoscope, they are available at the diameter ranging from 1 to 10, diameters of more than 6 mm diameters. Whereas the fibroscope, you can get fibroscope of 2 mm, or fibroscope you can get of 4 mm, 3 mm, likewise. So you can pass through a very narrow hole or the orifice into the internal organs. Now coming to the flexible endoscope and rigid endoscope, what are the markets? In markets, what different types of scopes are available? In flexible endoscope, you will get range from less than 1 millimeter diameter to 14 millimeter diameter. But mostly in veterinary side, more than 2 millimeter diameter, the flexible endoscopes are commonly used. And the length of the scopes are ranging from 55 centimeter to 170 centimeter. These are the longer scopes. These are used for some enteroscopy or any large animal you can have. I'm very proud to say that in Department of Surgery and Radiology, Veterinary College, Anand, we have almost full range of all scopes. We have gastroscope, we have a thalasscope, we have a thalassectoscope, we have a enteroscope, we have the cystoscope, we have a flexible endoscope, we have the fibroscope. So all scopes, whole armamentarium of the scopy are available with us. And the photos which I am going to show you today, they are of our own department. Most of the photographs you will find that these photos we have taken here in our department in clinical cases. So this is a very interesting thing. Now this setup, when you have everything with you, now this is to be kept in a car. A perfect room is to be designed, or you should have a perfect place where you can keep all this assembly. So trolley is required. So you can keep the monitor, you can keep the video processor, you can keep the endoscope, and all these things are components of the video endoscopes are to be kept on a trolley. So this kind of trolley you require for keeping. So you have a control section, you have a LCD monitor, you have a light source from where you can put on, and at the same times the ergonomic arrangement of the room should be such that the instruments, whatever you want during the surgery or during endoscopy, should be kept handy so that you can, while doing endoscopy, you can use them. So this is regarding the various accessories. So most of the endoscope of nowadays xenon light source they are using. They are using xenon light source, whereas the suction apparatus, they are also be attached at the trolley, so that with the help of this suction you can pass a suction, you can insufflate also the content, the distilled water during the procedure for cleaning the scope. There are biopsy channels. Through this biopsy channel, you can pass various brushes. The leakage tester, there is a leakage tester, there is a channel for leakage tester. So after every procedure, endoscopic procedure, you have to see for the leakage if it is there. And the 4-way deflection tip, and the knobs are available on the handpiece. So with this handpiece, there is a specific arrangement for holding also. you have to hold the scope in a such a way that it becomes easier for you to handle the scope, handle the various knobs, and at the same time, you are also piercing through the internal body cavity while you are doing the endoscopy. Now, there are the various brushes, forceps, which are passed in the channels: biopsy forceps, grasping forceps, cytological brushes, polypectomy snares. These snares and these instruments, they are passed to the channels of the endoscope for surgical maneuver or for the biopsy or for removal of the foreign body. Now, let us understand what are the different indications of endoscopy. Now, when we are examining esophagus through endoscopy, it is known as esophagoscopy. Likewise, gastroscopy, enteroscopy, colonoscopy, then rectoscopy, colposcopy, histoscopy, falloposcopy. So these are all named, based on the organ which you are examining. Almost all internal organs, they are being examined. Even joints, arthroscopy, thoracoscopy, and the laparoscopy means abdominal cavity hole. You can examine the help of the scopes. Now let us go to the various procedures of each and every scopy. So let us understand how esophagoscopy is useful. What are the indications of esophagoscopy? Before starting for any scopy, I am requesting all the veterinarians that this scopy, before scopy, you should have all the other diagnostic tests. You should get the blood diagnostic, blood parameters to be undertaken. You should go for plain radiography. If needed, you can go for contrast radiography. You do ultrasonography, and then if you feel that now this is the proper case wherein you can go for endoscopy for further diagnosing or further confirmation of diagnosis what you have made, then it becomes easier. You should not jump immediately after seeing the case to an endoscopy or perform endoscopy, because these are all set procedures, diagnostic imaging, and one by one you have to keep on. Now, what are the cases, what are the symptoms when they are presented in clinical case, then you think for doing esophagoscopy. So investigations of clinical symptoms with esophagus disease, regurgitation is there, difficulty in swallowing, painful swallowing, excessive salivation, inability to swallow. So these are the symptoms when shown. Dogs are presented with variable symptoms, but there are systemic causes are also there simultaneously, which causes this kind of symptoms. So you have to go for first various tests, and after that you have to decide whether the patient is suitable for endoscopy or not. So esophagoscopy is very easy. You have to prepare the patient for the esophagoscopy. So you have to keep the animal fasted for 24 hours, and for large animal only at least for 36 hours. General anesthesia is to be given. Mouth gag is to be placed. Animal is taken into left recumbency on the table, and after confirming that there is no leakage of the GIT, you can very well go for the esophagoscopy. And gastroscope, you can use gastroscope with less than 9 millimeter diameter. Most of this time, depending upon the size of the breed, you can use 9 mm, 8 mm, 7 mm scope. But this just gastroscope, which are available in the department, or the all commonly used gastroscope, they are 9 millimeter in diameter and having length of 130 to 155 centimeter, and they are used for upper and lower GIT endoscopy. The tip of the endoscope is lubricated before passing into the proximal esophagus, and then advanced down under a direct visualization, because you are seeing under the monitor that where you are going. And sometimes if you feel that there is some obstruction of the image, you can insufflate air, you can insufflate distilled water, you can insufflate, you can create a vacuum. Sometimes you can insufflate air, so the visual, the vision of the monitor or the internal organ becomes clear, and you can further advance your scope. So this is the normal esophagus mucosa which we have taken in our department, and this is a schematic representation how this esophageal sphincter, normal esophageal gastroesophageal sphincter looks. Now, coming to the esophageal foreign body, we have removed in all clinical cases. In most of the times during Uttarayan, we have seen that what is happening in Uttarayan time, lot of manja or threads which are lying here and there, they becomes the culprit. They becomes the, I mean, this dog, because while preparation of this thread with the, I mean, the glass, they put some eggs in the luddi, or they when they prepare, and these eggs smell which is present in the thread. So this dog will, or the cat will engulf or will eat those threads which are lying. And subsequently we get cases when thread is a culprit and thread is in the stomach. Sometimes thread may go up to intestine, starting from mouth to intestine, and causes enteroplication and create a serious problem. So this thread, the dogs come with a history of severe vomition and not responding to all medicinal treatment. Then such cases are when subjected. We find while doing endoscopy that there is a thread inside. Very easily you can diagnose the presence of thread in esophagus or into stomach, and these threads are male culprit. Sometimes some cases when we get some foreign body or the bone pieces, because if a small dog is offered some fish or some fish hooks, some dogs they are offered the mutton, the bone pieces they engulf and they gulp, and after gulping these bone pieces they are obstructed, they are obstructing somewhere in esophagus, or sometimes they are in the stomachs, and they are causing, they are actually culprit for symptoms what you get. Now some foreign bodies are also there which you can visualize under the during esophagostomy, and you can also remove them with the help of the endoscope, I mean with the help of the channel of the endoscope, or you can remove from the esophagus with the help of the, that is the forceps, while animal is in the anesthesia. Now coming to the esophageal diverticulum. In one of the case I remember where there was diverticulum of the esophagus, we diagnosed with the help of endoscopy. We did endoscopy also. So this case, when such cases are coming to the department, we should, I mean, select those cases, perform endoscopy to diagnose. These are the various conditions. Now in these cases, esophageal polyps you get. So different types of cases which we have come across, wherein in case 1, case 2, case 3, the different locations of polyps in the esophagus, which causes, these polyps can be very well removed with the help of the esophageal snare or the instrument channel. And coming to the now gastroscopy, after esophagoscopy, now the stomach, again stomach, the symptoms are almost nausea, dogs or the patients with a history of nausea, chronic vomiting, not responding to medical treatment, sometimes hematemesis, melena, or unexplained anorexia. So such patients, we should go for the examination of the stomach with the help of the endoscope. And therapeutic endoscopy, this not only act as a diagnostic, but you can select the type of instrument for removal of some foreign body if they are present in the stomach. So the procedure of gastroscopy, wherein you require a flexible endoscope of almost 9.8 millimeter diameter with 120 centimeter length. But for a cat and a small dog weighing 5 kg, you require a little less diameter of the endoscope. Gastroesophageal sphincter you can visualize, which is usually closed, and when you insufflate air while doing endoscopy, this opens and you can enter into the stomach. When you enter into the stomach, the vision of stomach is visible, and I mean when you see the stomach, for examination of the whole stomach, J maneuver, what they say is retroflexing the scope, means with the help of deflection knob, you can right, left, up, down, deflection of the tail piece of the, or the end piece of the endoscope, and the whole of the each and every corner of the stomach with the help of endoscope you can examine, and a better picture of which you can visualize over the monitor. And you can also inspect pyloric sphincter, and pylorus is also inspected during the procedure. So how this is done, now let us see how this is done. When you pass your endoscope into the stomach or gastroscope into stomachs, the various anatomical part of this stomach can be visualized. You very well know that after pylorus there is an entry for pyloric entry. Pylorus enters into the intestine, duodenum. You have two parts, fundic part as well as pyloric part of the stomach. This is gastric mucosa, and the in between this pyloric and fundic part, there is a incisure angularis. This is the anatomical, I mean, this portion which divides, I mean, two part of the fundus. This also you can very well locate while doing. And this is the schematic diagram of normal stomach view. Now let us see what are the different foreign bodies are removed, or we have done a lot of esophagoscopy, I mean gastroscopy in dogs, and we have removed so many things. So let us see what are the different things and foreign bodies. So sometimes you can get endoscopic view in the stomach. Sometimes you will get to see hemorrhagic gastritis, means there is the erosion of the gastric mucosa has taken place, and there are hemorrhagic type of gastric mucosa you can see. You can see ulcers present in the stomach. These are the pictures of the internal pictures of the stomach. Sometimes you get to see bile tinged fluid in the stomach. In some cases where there is a lot of biles which is present, and you can see into the stomach. Now see, this is the video which I am showing it to. So now in one dog was presented at Department of, now this is of a horse. This is of a horse. Okay. Now one horse was presented with a history of prolonged anorexia in Department of Surgery. And the history was like the animal was transported from Punjab to Gujarat. And during transportation, the animal was tied with a rope at the nose. And because of the nose, there was secretion. The maggots, they got entry into the stomach through esophagus. And there was a lot of maggots or the worms which were present in the stomach of a horse. And this horse was anorectic. So the this is a, I mean, the gastroscopy of a horse stomach we have done with a large animal video endoscope. So we have in a department large animal video endoscope. With this we did this gastroscopy in case of stomach. Now what are the other type of pictures which you can see through stomach, inside the stomach? Punctate erosions, gastric lymphoma, stomach worms, gastroesophageal interception, pyloric hypertrophy. So these are the various pictures which you can video, second video. You cannot see, I mean, now there is various cases which we have done with retrieval of gastric foreign body. So this is a video showing, or this is the pictorial representation of the case wherein we did contrast radiography, and one dog was having eaten a socks, and we did contrast radiography, and we found that there was this presence of shock in the stomach, and we did sonography also in the same. And when we did endoscopy, we found that the shock was there in the stomach, and the shock was removed through endoscopic channel from the from the stomach. Now in one more case where we found the stainless steel bowl, small stainless steel bowls was eaten by, there was a history, honor has told that we offered ice cream to the dog, and this ice cream cup was of stainless steel and was engulfed, and it was eaten by a dog. And we took X-ray plain radiograph, it was visible in the stomach. We did contrast radiograph, we did endoscopy, video endoscopy to remove that cup, the stainless steel cup which was present in the stomach. Now let us see the video of the removal and the whole procedure. So this is the small stainless steel cup which was there, which was snugly fitting into the esophagus, the portion of the pyloric and the between the pylorus and the fundic part of the stomach, and this was visible. You can very well see this bowl which was present inside.
Sir, sorry for disturbance. Video is not playing. Video is not visible.
Video is playing here, sir. Okay.
But no one can see.
You will have to play it separately.
Please play separately.
Okay.
Please. उनके सोर्स में होगा तो दिखेगा।
I think now it is.
नहीं दिख रहा है सर।
Davos gibi şey. Davos ya.
Ay, que é um cara, meu avô.
To suke shi ho tam to go wi. Tuji lactobacillus syphilis infection.
Now you are able to see the.
Yes, yes.
Okay. So this is the video showing the stainless steel bowl which was eaten by a dog, and it was in the esophagus, the fundic and the pyloric between snugly fitting. So we tried to remove the plain radiograph and we diagnosed. After diagnosis, we did the gastroscopy. We passed a grasp forceps to instrument channel. Now you see the grasping channel. We passed the grasping forceps, and this grasping forceps, when we passed, we were able to hold the cup. We were able to hold the stainless steel cup, but we were not in a position to bring them back through this esophagus. So we performed, in this case, gastroscopy and removed afterwards. Now the whole video, is a very long video, so we will see grasping procedure, how this is to be done in the clinical cases by passing a grasping forceps through an instrument channel. A forceps is to be passed crocodile jaw or the alligator jaw, and this grasping forceps was used to catch hold, but somehow it was snugly fitting and there was lubrication. This saliva was so much snugly, so we were not in a position, so we had to perform gastrotomy to remove the this SS bowel from the stomach after doing gastrotomy. Now we have got a lot of other videos also. So I'm showing you a few more videos wherein the foreign body was removed through gastroscopy. Many bone pieces, in one of the case I still remember the the brushes, this clothes cleaning brush, 2-3 such brushes are eaten up by great dent, and we did the endoscopy. We found that stomach was full with this kind of stuff, and then we removed it through the endoscopy forceps. We have removed a lot of other things. In one more case, I still remember. Sharing presentation. So in this case, I remember there was a toy laughing Buddha, which we called as a laughing Buddha. So this base of the toy, base of the laughing Buddha toy, which was eaten up by a dog. And dog, you can see in X-ray, the laughing Buddha, the base of the toy. And this was through endoscopy, we were able to see the, I mean, this piece inside. And we removed this base of this. This is again a wire which we saw through endoscope. There was wire which was present in the stomach. And this was the wire which was removed through endoscope. Now, coming to the enteroscopy or intestine examination, you should have a long endoscope for that. And you can do proximal, you can go up to proximal jejunum only, from duodenum and you cannot go beyond that. So entire small intestine cannot be possible through endoscopy. So small bowel, some cases of small bowel diarrhea, protein-losing enteropathies, chronic vomition cases and melena cases, the dogs are subjected to enteroscopy for detailed examination. And the various symptoms, various lesions you can come across are the duodenum mucosa and papillae, these symptoms. I mean, the lesions. The pear patches in the lateral wall of the jejunum. Some hookworms are there in the intestine. Some duodenal ulcers, if they are present, you can see through duodenoscopy. Adenocarcinoma of the duodenum also you can identify. Erosive duodenitis also you can identify. So number of lesions which you can come across while doing enteroscopy. Now coming to the coloscopy or colonoscopy. So whenever there is a dogs or small animals are presented with a history of difficult in passing feces, dysphagia, tenesmus, chronic constipation, diarrhea, and there is fresh blood and mucus which is coming, and such cases you can subject for proctoscopy or colonoscopy. So with the help of the, before doing colonoscopy or proctoscopy, you should give enema, and thorough cleaning of the large intestine of the, or the large intestine colon of the dog is to be done before introducing any of the scope. When you do colonoscopy or pass the rigid scope into the rectum or proctoscope into the rectum, what you will see you can see some worms inside. You can also see some of the erosive lesions, ulcerative colitis or ulcerative lesions of the colon you can come across. So these are some of the clinical cases where you can see the different type of lesions in the gastrointestinal tract and can be very well easily diagnosed with the help of the esophagoscope, gastroscope and enteroscope. Now coming to the urinary system, that is a indication of cystoscopy. So when the cases are presented, because clinicians, all those who are practicing, they get large number of cases of cystitis, hematuria, then difficulty in passing urine, urinary incontinence, and cystic calculi or urethral calculi, neoplastic conditions involving the urinary bladder. And these cases are first subjected to radiographic, and after radiographic you can perform ultrasonography. And when you want to confirm that whether this is really a case or where you can go for cystoscopy. For doing cystoscopy, you should have a flexible cystoscope. So there are two types of cystoscope generally used. Straight, the rigid cystoscope, you can use it in case of female, because in female urethra is short and it is wide, whereas in case of male dogs, the urethra is very small, penile urethra is very small, and introduction of scope into the penile urethra, flexible video endoscope you cannot pass through. You have to pass through a flexible fibroscope, which is having diameter of 1.2 millimeter diameter. You can pass. Just 2 days back, we did one cystoscopy also, and we found that there was a tumor inside the urinary bladder. So all the patients routine preparation, an animal is to be general anesthetized and kept on the ventrodorsal position. And before doing in male dog, always you have to pass a urethral sheath, because when you pass the urethral sheath, your scope is protected. Because if you are not passing a sheath before introducing the scope, your your scope get damaged. So a insertion of urethral access sheath is very important. And after that, the insertion of flexible and fibrotic endoscope with the simultaneous infusion of normal saline through working channel, so that you can get to see. So this is the assembly you should have for doing the erythrocystoscopy in male dog. See, this is the urethral sheath. This is urethral sheath is like a catheter which you can pass, and after that passing the catheter, the scope is also passed. And when you pass the urethral sheath and slowly above this, you can pass a sheath, and you can see various lesions which is present in the urinary bladder. So this is a case of cystitis. There is a hemorrhagic cystitis. There is a lot of stone cases you can very well identify. Stone otherwise also you can identify with radiography and other places. But with this also, the type of stones, these stones, and in advancement, with advancement you can do lithotripsy also here, and with the laser guided. And this tumor cases also, transitional cell carcinoma, can also be diagnosed with the help of the erythrocystoscopy in dogs. So erythrocystoscopy is one of the important tool for diagnosis of the lower urinary tract, particularly up to the urinary bladder, wherein you can give various type of symptoms. Now coming to the thalassoscopy or thalassectoscopy. Thalassoscopy. So here in thalassoscopy, there is direct visualization of the teat sinus using a rigid telescope called thalassoscope or mammoscope. So what is happening in most of the dairy farms? There is after parturition, there is the owner complains that though animal has got milk in the udder, but milk is not coming out. So such cases, large milk dairy owners, they come and you have to pass for diagnosis, because if the obstruction is at the tip of the orifice, you can very well palpate. But when obstruction is there in between the teat canal or at the base of the teat canal and udder cistern, with the help of thalassectoscope you can operate. So you should have an assembly. We have a full range of technopat for thalassoscopy and thalassectoscopy set of instruments. This can be carried into the field. That is we'll show you the various part of it and the procedure also. So these are the various parts of the thalassectoscope. So there is a main unit. This is a main unit. This is a telescope, 1.9 mm telescope. This is fiber optic cable. This is connecting cord. These are the trocar and cannulas for passing into the teat canal. This is the handpiece. This is the handpiece and cutting loop. This is for with the thalassoscope, resectoscopy attached, light source, foot switch, contact pad. So these are various parts of the whole assembly which is used for thalassoscopy and thalassectoscopy. Now, how this is to be done? So in a cow, when you want to perform thalassoscopy or thalassectoscopy, if you have a travis and if you have a arrangement for keeping the animal in a standing and performing, it is good. Otherwise, you can make the animal in lateral recumbency and also you can do. We have a provision, a separate travis for thalassoscopy and thalassectoscopy, where a surgeon or the endoscopist can stand in a deep area and he can have access of teat and other parts of the body so that he can introduce while standing inside. So we'll show you the photograph. Minor procedure with cow standing, restrained in a chute, light sedation. If it is the cow is indigenous, you should do light sedation. Otherwise, for a Holstein Friesian and Jersey, a light sedation is very useful. You have to do ring block at the base of the teat. After doing ring block or inverted V block, and you have to infuse some local anesthetic into the teat canal before doing the procedure. So this will not cause any pain during the procedure. So animal is restrained in the, or this buffalo is restrained in the travis, and you can see the surgeon or the endoscopist can stand in a pit or in a place which is lower than the height of the animal. So he can very well address the teat. And first, after tying a tourniquet at the base of the udder and teat, you have to first insufflate. So air inside with the help of a syringe, air is to be introduced. After introducing the air, this thalassoscope is to be passed. When you pass the thalassoscope inside the teat canal, you get various type of obstructions figures or the pictures depending upon the mucosal adhesions which are taken place in the teat canal. The adhesions you may find somewhere in between the teat canal and at the base of the teat. Sometimes you may get adhesion at the teat spider or at the teat canal and the udder cistern. So these are the different type of telescopic appearance of membranous obstruction which you can come across while examining telescopy. Now you see this video. I'll be showing you because I think video will in end I will show you video, because this video, if you are able to see, then you see there is a membranous obstruction in the mucosal adhesion is there all inside. So these mucosal adhesions, they prevent the milk which is present in the udder coming through the teat canal. So this kind of adhesions are there in the, so this kind of adhesions, they can be removed with the help of thalloresectoscopy. The thalloresectoscopy used to examine and resect the bovine teat. So this thalloresectoscope is introduced through the teat canal, or it can be introduced through lateral puncture into the teat. But we have used most of the times through teat orifice. It was introduced inside. And when you introduced inside, before introduction of the rigid endoscope, we have to put a cannula. So this trocar is to be first introduced after giving local anesthesia, surface anesthesia into the mucosal surface of teat canal. A trocar is passed. After passing the trocar, we have to pass the thalloscope with resectoscopy assembly. So when you pass the thalloresectoscope and you can identify the place where the obstruction is there, then you can, with the help of resectoscope, with help of cautery, you can fulgurate the mucous membrane. The mucous membrane cuts very easily while touching only, and at the same time the normal saline are also passing through the channel, so that it will not generate lot of heat and will not damage further the mucosa or the internal structures of the teat canal. So you see how this is to be done in a video. So this video shows that the fulguration of the teat obstruction, which is done with the help of the cautery. So this is a cautery which is passed through thalloresectoscope, and when it come in contact with the mucous membrane, it cuts and the patency is established. The milk comes out through the teat canal. Immediately the owner becomes very happy. Owner gets satisfied that okay, the milk has come now. So this kind of thalloresectoscopy and thalloresectoscopy is very useful for diagnosis of the now with the help of various scopes like otoscope, you can do examination of the ear, that is otoscopy. So otoscopy can be done with the rigid endoscope mostly. So with one non-working hand, you have to lift the ear pinna with non-dominant hand and upward position, and you have to introduce the the straight rigid endoscope into the intrinsic incisors, and when you pass into the canal, you will get the figure. And here also the same scope, telescope, that is the 1.9 mm telescope, can be used for examination of the ear as a otoscope. Now in this you can see the various ear lesions were also been routinely we are doing some cases wherein the rigid endoscope was passed in a dog ear, and this is the normal ear canal you can see, and this is the ear canal with there is a normal tympanic membrane is there, and here you can see excessive hair which are present in the ear canal. Some tumor, if it is there in the ear canal, you can very well see. Some maggots, if they are deeply embedded into the ear canal, you can very well see them. So these are the cases where you can see various with the help of otoscopy, laparoscopy, or any of the surgeries of the abdominal which is done with the help of the laparoscope. I have told you that it is a minimal invasive surgery with the help of laparoscope, wherein we worked long back in 2007. We did laparoscopic sterilization, laparoscopic oophorectomy in one of the postgraduate research. So laparoscopy is a one kind of modality which is designed for visual inspection and operative procedure for the abdominal cavity. So the practical application of laparoscope, nowadays most of the surgeries are being done with a minimum or keyhole surgery. Concept of keyhole surgery is very common nowadays in human beings, as well as these concepts are being very well taken up by veterinary field also. Now in overseas, most of the surgeries in pet patients are done laparoscopically. So now there is a lot of development in the field of laparoscopy also. So OHE, ovarian hysterectomy, is done with the help of laparoscope. So here you have a different ports through which you can pass a telescope, you can pass a light, for a telescope for light. You can also pass instruments through that ports into the abdominal cavity. Before that, you will, insufflate. So general anesthesia, animal is to be secured in a supine position, and rigid endoscope of 5 millimeter scope with camera attachment is introduced. Before insertion of telescope, you have to pass a varus needle and pneumoperitoneum by insufflating carbon dioxide. You have to ballot the abdomen, then you have to make a various port without injuring the internal organs. After that, after placing the ports and passing the instruments, the ovaries or the part which is to be the surgery which is to be done can be performed, and after that the closure of the, so this is ergonomic arrangement or position of the surgical team and placement of the scopes. So this is, in a very short time, it is very difficult to make you to understand about the laparoscopy, but now it is a well-known laparoscopic surgery. So I'm not going into the detail of the laparoscopy. These are the instruments which are used for laparoscopy, various scissors. Now there is a lot of advancement, newer and newer generation instruments are available for doing this kind of scopy in human as well as in veterinary field. Now with the advancement of the field of the endoscopy, now these are the some photographs, insertion of varus needle, placement of port for oophorectomy, trocar. These are our own photograph, wherein ligation of tightening of loop. These all surgical laparoscopic surgery has got a very steep learning curve. You have to keep practicing. If you are doing with on simulators for number of times, then you can dextine yourself and perform this kind of surgery in human as well as in veterinary patient. Now, the rhinoscopy, that is the common complaint associated with nasal passage, that is sneezing, nasal discharge, epistaxis. This nasal passage, upper nasal passage, I want to talk. So upper nasal passage can be examined with the help of a rigid endoscope, whereas for flexible endoscopy, you can you can go up to the bronchial level after passing into the trachea. So tracheoscopy or bronchoscopy can also be done. So rigid endoscope, you can pass into the nasal passage and you can do rhinoscopy for examination. In horse, if you get a lot of horses, and in horses, this kind of lesions, by passing scope, you can see they are rhinoscopy of the, these are the common rhinoscopic, the pictures of the horses. Now, clinical cases where ethmoid hematoma in a horse, when you pass a rhinoscope or the telescope inside the nasal passage, you will get to know about a hematoma which is present in the in persistent bleeding. There was a persistent bleeding case and we found that there was hematoma. Foreign body in ventral concha of horse can also be diagnosed with the help of a rhinoscope or telescope. Now again, for dogs also, the same type of scopes, depending upon the size of dog, can be passed into the bones, and you can see the scopes and you can examine the normal nasal passage as well as some abnormal, if they are there. Some blood clots are there in the nasal passage of a dog, of a bleeding. If the history of bleeding, you can get to see. We get large number of cases where there is a fungal infection is present in the nasal passage, and this fungus, particularly Aspergillosis colonies, they are very well seen when you pass a scope inside the nasal passage. With the history of slight, the bone becomes tender over the nasal passage, and when you pass a scope inside, you may get to see sometimes these Aspergillus colonies, and this type of cases are very well diagnosed, and you can give treatment accordingly. Some tumors are also present in ethmoid bone, and in some of the solid masses of the respiratory carcinoma are also there. In turbinate bones particularly, they can be diagnosed with the help of the nasal passage. Now coming to the chronic coughing cases and other cases with other symptoms and complications, these cases are subjected to respiratory endoscopy, and you can very well diagnose them, and you can therapeutically remove the primary cause, and treatment is to be given. So these are again the pictures of the nasal passage, or where you can see various type of lumen in the trachea. and various part of the respiratory passage to diagnose the case and to clear the conditions. Polypoid mucosal nodules, some intraluminal tumor obstructing the left principal bronchus, you can diagnose. Bronchial foreign body, if it is there, you can do. But for passing a endoscope into the trachea and further into the bronchus, you need to have a video endoscope, not the telescope or not the rigid endoscope. You need to have the now coming to the arthroscopy, wherein the rigid telescope is passed. Now arthroscopy is examination of joint through a telescope, and arthroscopic surgery nowadays is becoming very common in human patients, where they go for different type of joints treatment and diagnosis. So these are the set of the instrument. Basically the rigid telescopes are used. I mean, these type of telescopes, they are used for, and these are the instruments which are used for telescope passing. For doing arthroscopy, you have to do arthrosynthesis first. So you have to, there are special places from where there are anatomical locations from where you can enter the joint space without disturbing the joint. And after that, after passing a cannula, you can, through that cannula, insertion of cannula, you can pass a a telescope, and you can see the inside of the joints. And when you see inside of the joints, you will also come to know about the lesions which are present in the joint. So this is various normal joint pictures, and here we will show some of the affected joint pictures also. So normal shoulder joint, how it looks, normal elbow joint, how it looks. And if there is a OCD case, osteochondritis dissecans, that is, involving this is the radial head. This is the radius ulna, and this head of the radius, and there is a osteochondritis inflammation of the OCD. This joint forming the the elbow joint. So here you will come to know about the various clinical cases. Also hip joint, also you can do arthroscopy of hip joint, and you will come to know about erosions of the femoral head, articular cartilage, with the help of the telescope. And these are some of the cases of hip joint. Many times we get hip dysplasia cases, and these hip dysplasia cases, whether we should go for, we will subject them to some surgical intervention or not. So one has to go for this kind of arthroscopy and then decide whether you should be. Now this is all about scopy. There are a number of internal organs can be examined, surgeries can be done with the help of scopy and instrumentation. Now the important thing for veterinarian is how to proceed for the purchasing of instruments. Now people, if you go through in overseas market, there are they use lot of scopes for human beings, and this used scopes they throw into the developing countries after refurbishing to the secondary market. So these scopes are available at a cheaper cost, but we should be very careful while purchasing those scopes, because those scopes which are used, the life and the quality, picture quality which you are getting, one should have a practical demonstration of the scopy done on a clinical patients for number of times, and after that they should go for purchase. The size of the scope which is to be purchased, the type of practice veterinarian is having in the area, that is very important, because the scopes are very costly. The client, what are the different types of clientele he has, what type of practice he is doing in the area, what type of patient cases he is getting. So based on that, you can go for purchase of the, and this purchase of instrument is not the end of the endoscopy. Again, we have to keep them properly for repeated use. So this is very important. Purchase of scope or telescope or instrumentation in your armamentarium and maintaining them in up-to-date condition for repeated use is very, very important part. So this is about the keeping these instruments properly. You have to clean them properly. So after each procedure, wipe scope down using a soft cloth and remove residual organic material. Flush the channels with the enzymatic cleaner, non-corrosive, non-abrasive, neutral pH cleaner solution. Rinse the outside channel and with the demineralized water, because if the water is mineralized, ordinary water, the scopes will have a deposition, and your picture quality over a period will reduce. With the help of clinical brushes, the brushes in the channel, you can very well clean. And after disinfecting and within a, glutaraldehyde, or many of the companies, they have their own specification. According to that, you have to sterilize the scope, and after sterilization of the scope, immediate after, the scopes are kept in a hanging position. In our department, we have a cupboard like this. So we, after use, every use, we keep the scope in a hanging position so that it drains the whatever water or insufflation of air or content which is present, which drains out. After that, cleaning and everything, the endoscopes are properly stored in a convenient and safe place. So this is about the, now you see the feature perspectives. Now endoscopy has advanced. Now the endoscopy for the rest of the GI tree, I mean the large, I mean the intestine examination. The capsule endoscopy has come. Nowadays it is more proper, I mean in the human beings, where whole of the digestive tract can be examined through endoscopy. So a capsule, patient swallow the capsule and it takes the picture inside of the gastric to examine the areas of small intestine, which is otherwise you cannot see through endoscope. So it takes about 24 to 48 hours to pass through feces, and this will contain, this capsule will contain electromagnetic, I mean the picture, I mean this will be read on the monitor, this fluorescent and all these pictures which you can retrieve after once capsule comes out in the feces. So this kind of recent advancement, along with that, there is a flexible endoscope nowadays are available with a zoom enabled magnification. You can get 100 times more magnification. So you can minute detail on the mucosal disorder. If they are there on the intestine, you can very well diagnose. Sometimes nowadays, the ultrasound devices, they are on the tip of the flexible endoscope. They can be passed along with the endoscope to examine the pancreas and hepatic portal system. Now this is, you can say that this is really marvelous with this kind of ultrasonography machine on the endoscope tip, which will you get picture of various portal system and pancreas. And now again, one step ahead, the robotic surgery has come up in the human market or even in veterinary fields. So this robotic surgery has revolutionized many aspects of the laparoscopy and thoracoscopic surgery. So in laparoscopic surgery or thoracoscopic surgery, as I have told that there is a steep learning curve. But when these robots, they are used for laparoscopic and thoracoscopic surgery, the tremors which comes with the age of the surgeon on the hand, robot can very well, because robot, I mean, with precise incision, the identification with the help of telescope part, he can do surgery, robot can do. The surgeon has to sit on a console and he has to sit on a console and he has to operate from a distance place. So this is all about the development which has taken place in the field of endoscopy and laparoscopy. Now coming to the end of my presentation, conclusion. So these are with these few points. So you all know the flexible fiber optic endoscopy have revolutionized our approach to diagnosis. It permits direct visualization of internal organs, gastrointestinal tract, urethroscope, urethrocytoscope, thalasscope, thalloresectoscope, otoscope, and laparoscopic surgery. These all scopy, and they are very useful for diagnosis of internal structures. And nowadays, now you can say that the someday in the future, people will look back at a regular surgical incision as something archaic and barbaric. We have Kurt Sim to thank you for that. Just one story I would like to tell you at this. Kurt Sam, he's the man who has developed, he's a father of laparoscopic surgery. Now, when he was presenting his paper, as I have told, his colleague, they unplugged the projector and they told that this laparoscopic surgery is barbaric. I mean, this laparoscopic surgery is reckless. It is useless. You should not perform this kind of surgery. Then once again, he continued working on the laparoscopy only. He became a visiting professor in Yale University. There also he started doing laparoscopic work. And his colleague told that Sam, you get yourself, your brain you should get scan of your brain done because your brain is damaged. Why you are spending a lot of time on laparoscopic surgery? But when he first demonstrated laparoscopic surgery in a first cholecystectomy was demonstrated in a clinical surgery was demonstrated, and later on the development, you know. So we are thankful to Kurt Sam for that keyhole surgery concept, or the tiny hole surgery or keyhole surgery concept, which we are nowadays, the development we see is because of the Kurt Sam. So with this, I stop my presentation, and I request all the delegates, please, or the attendants, if you have any doubts, please.
Thank you very much, Dr. Parikh sir, for such a nice presentation and informative lecture. So now I request participant, please any doubt, you can ask from sir.
Yes, can I have interaction?
Yes, sir, please.
Yes, thank you, Professor Parekh. This was a very nice presentation. Really, I enjoyed this presentation, detailed, and that too, these all photographs and procedures being conducting in your this clinic. That's really applauded, and I do salute you for that. I have a very simple query. Our that's when you are just demonstrating all these procedures, and you said there is a set procedure that you should go for other tests like those X-rays and all that. I don't think in many of our human, practices, since these copies are very, a safe method rather than those X-rays and all that. They and probably in many of the cases you don't need for if you have in case of humans you have any say these problems with your this gastric problems or esophageal problems or even those rectal problems. They never go for those X-rays and all that. They simply go for these endoscopies or you can say proctoscopies and all that, because probably this is a very safe rather than the X-rays. Is not that true with the veterinary side also?
No, you are right, sir. The human being, they definitely, they are the gastric problems. I have seen the, the endoscopist will straight away without doing other examination, straight away go for the this kind of endoscopy very easily. But in veterinary patient, I'm talking about veterinary patient because everybody cannot, only very few institution in India where they have got the facility of endoscopy in veterinary patients. Furthermore, the symptoms which we are getting in dogs, they are variable compared to human, because animal with some systemic disease, some animal is with a systemic disease will have a chronic vomition. Suppose dog with a end stage renal disease, dog with a end stage renal disease will continuously vomit. Hematemesis you will get. And in this case, if you are going for general anesthesia and endoscopy, you are end up with problem. Sir, so what is happening is why is done because the dogs in our veterinary patients, the other test, particularly the X-rays, sonography, with this you can very well sometimes come to a conclusion, and if selected patients you can go for, and accordingly in your private practice you can charge for. And in a very few institutions in India where they have got the facility for thalasscope, thalareceptoscope. I'm working as a head here, and I know since last 10 years our department is equipped with all kind of scopes. And recently I was not having urethrocystoscope, that was for male dog. So last year I purchased, that is a urethrocystoscope, fibroscope for male dog. So this whole procedure, of course, human being and veterinary patients, they differ. Some liver disease, there is a vomition. There is a kidney disease, there is vomition. Some gastritis, viral gastritis, there is vomition. So all these cases, you cannot subject for immediate endoscopy. So I think,
Thank you. Thank you. Thank you.
doctor, you are
Very nice
satisfied?
of you, sir. So nice of you. Thank you, sir.
Question from the audience.
Good morning, sir.
Yes.
Sir, myself, Savan Froda, PG student. I want to ask question. Which specific oral cleanser you use before performing colonoscopy?
Which?
Specific oral cleanser.
Most of the time, for doing colonoscopy, enema is preferred. If you do enema before doing any colonoscopy, enema is to be given. A sodium phosphate enema you can give. You can use proper cleaning of the rectum with the help of and at the same time, the previous doing, if animal is kept fasted and you are calling on the day, and you can, this kind of procedures are, in a routine way, wherein the enema will make the rectum free, and you can, oral cleanser or laxatives are many, but the important thing is you have to make the rectum empty before the actual procedure. That is very, very important.
Okay, thank you, sir.
So, sir, a number of participants have asked the queries. So some of important queries I have read. You can clarify them. So please.
Dr. Mukesh Patil have asked that is endoscopy useful in diagnosis of irritable bowel syndrome?
Whereas in IBS, inflammatory bowel syndrome, the inflammation is always there. So this kind of are also, this scopy, particularly the colonoscopy, particularly the inflammatory bowel syndrome, they are most of the time immune mediated also, so far I know. So in some of the cases where the lesions are there in the intestine, you can see. But to rule out some of the autoimmune disorders, this can be checked for. But this can be very well done with the help of, this scopy. So a condition can be diagnosed. Inflammation can be very well diagnosed.
Thank you, sir. Next. Is there?
There is one more question that will you recommend the person, the genuine Indian supplier of endoscopy attachments in India?
Actually, we have a full setup of Karl Strohs. They are pioneer in manufacturing Karl Strohs are pioneer in manufacturing the scopy. And we have but one thing I would like to tell to everybody, that these people, company people, they are also very wise in selling their products. So what is happening of late, what we have observed through our experience, that they are not telling you about the detail of the scopes. Many times the scopes, you need to have only 3 or 4 type of scopes, but the common assembly like light source, then the video processors, and then the other attachments, the channels and everything will be a permanent feature. So you are not supposed to purchase every time the different source, different light source for every setup. You should have a fixed setup in which all type of scope can be attached. Such provision you should make. In that way, you can, with minimum setup, you can, save money, and you can have many instruments in your many scopes in your armament area. Because what is happening is, some laparoscope you want to purchase, the monitor for laparoscope, monitor for the endoscope, monitor for the fibroscope can be one, and in that monitor in that light source, in that connector, all these scopes, if they are attached, you should not to repeat the various kind of scopes. And Karl Stroh's instruments, I found them better because we are using here. The quality is better. We have got large animal video endoscope. We are doing. We have got theloscope. We have got theloreceptoscope. We have the scope. We have the gas. We have the enteroscope. I mean, all sets of instruments we have, and these are fitting to a cart in which we keep everything inside. So this is with this Karl Stroh's I recommend.
So there is one more question, that how can we diagnose ulcerative colitis with the help of endoscopy?
Endoscope, you can do coloscopy, ulcerative colitis, coloscopy, rigid coloscope, any telescope you can pass after backracking or after emptying rectum and colon, you can pass.
Thank you very much, sir, for feedback. Chairman.
I think no more questions. So thank you very much, sir, for giving such a nice information. And now,
Thank you very much.
thank you very much, sir. So now we have switch on to second speaker, Dr. S.K. Jirwal, Assistant Professor.
Thank you for giving me an opportunity.
Thank you, Parikh, for presenting
Yes, sir.
yourself virtually.
Thank you, sir. Thank you, sir.
Whenever COVID is over, keep coming physically also.
Yes, sir. Yes, sir.
Very soon there will be unification, administrative unification also.
Yes, sir. Yes, sir.
And your scope should be so lengthy that it should reach to Junagadh from the Anand. The distance should not matter.
Yes,
So,
yes.
keep coming, keep smiling. Thank you for
Thank you. Thank you. Thank
supporting.
you, sir. Thank you, organizing secretary, organizing dean, organizing faculty, the chairman, reporter, everybody. Thank you. Thank you very much.
Thank you, sir.
गिरवानी साहब को ले लो. आ गए.
यस सर. हाँ ऑन है.
Suresh.
Good morning everybody.
Good morning.
Dr. Suresh, you adjust your camera so that you are visible with full face. Yes, yes.
Is it okay, sir?
Yeah, little. You are just seen up to the lips only. Yeah, now you are seen like passport photography. Your chest should be seen so that you can appreciate how broad it is.
Thank you, sir.
How are you?
Fine, sir. Fine. Thank you, sir.
You are
All
welcome.
fine.
You are welcome.
Thank you, sir.
Pleasure that though it is virtually, we are meeting physically.
Yeah. We have met in 2019, sir.
Yeah, just recently we have deliberation from Anand and Dr. Parikh presented on endoscopy.
Yeah, sir.
So this is a virtual telescopy. From a long distance, we are able to see you and you are seeing us. I hand over to chairman to conduct the session further, please.
Thank you, sir. So, very good morning, Dr. S.K. Jirwal, sir.
Good morning to all of you.
Assistant Professor in Department of Veterinary Surgery and Radiology, Rajuwas, Bikaner. The topic of sir is advances in diagnosis of ophthalmic affections in dogs. So, Jirwal sir have 13 years of experience, 14 years of experience in the field of veterinary surgery and radiology. And sir, whatever the achievements and awards sir have given, so I request Dr. Ankita to elaborate the achievement and the awards of this.
Good morning, sir. Dr. Suresh Kumar is a renowned veterinary surgeon with 20 years of clinical experience. He became the first veterinary surgeon of Rajasthan state to perform successful cataract surgery by phacoemulsification method in dogs. Dr. S.K. Jirwal is serving College of Veterinary Science and Veterinary and Animal Science Bikaner, Rajuwas, Bikaner since 2014. He has strengthened the skill and facilitated his work of ophthalmology at different platforms and disseminated the knowledge as well. We have contributed a lot in small and large animal surgery, including ophthalmology, radiology, USA techniques of anesthesiology. Before joining the university as an assistant professor, he has served as veterinary officer in Department of Animal Husbandry, Government of Rajasthan for almost 14 years. He has screened more than 2,000 blind cattle for various ophthalmic disorders by a thorough clinical and ophthalmological examination since year 2018. He had performed surgery for diverse ophthalmic affections in cattle as well. He is member of 6 scientific national and international organizations. He have got many awards and distinctions received. He was awarded the letter of appreciation by District Administration, Barme, Rajasthan, for Best Clinical Administrative and Extension Services, awarded by Honorable Vice Chancellor Rajuwas for successfully performing cataract surgeries in canine using operating microscope. He was also awarded the gold medal for Best Research Paper entitled Clinical Evaluation of Electroretinography, that is ERG, for diverse ophthalmic affections in dog, awarded in 2018 by Honorable Vice Chancellor Rajuwas for being awarded gold medal for Best Research Paper in 41st Annual Congress of ISVSS at SVEU, Tirupati, Andhra Pradesh. He was awarded by District Administration Bikaner on the occasion of Republic Day for awarding gold medal for Best Research Paper. He was awarded second consecutive gold medal for Best Research Paper entitled Ophthalmological Diagnosis and Surgical Management of Cataract in Dogs. He was also bestowed with third consecutive gold medal for Best Clinician Award during 43rd Annual Congress of ISVS in 2008. So I request you, sir, the screen is all yours. Thank you, sir.
Thank you, ma'am. And now can I share my screen?
Yeah, yes, sir.
Sir, this is showing host disabled participants screen sharing. So I think you have to permit me. Now host, okay.
So it has been allowed, so you can share.
Sir, we can see your presentation. Please continue.
Okay, okay, sir. So, am I audible and visible to all of you, sir?
Yeah, yes, sir.
Okay, thank you, sir. So, a very good morning to all the participants and the team organizing this vocational training. And At the outset, I would like to thank Professor H.P. Tangshar, Dean of the college, and other faculty members involved in organizing this vocational training. And a special thanks to Dr. Talekar sir for contacting me to deliver this lecture. And I had an opportunity to visit the Department of Veterinary Surgery and Radiology at Junagadh in 2019 for a demonstration of cataract surgery in dogs. And as Tang sir just recalled, I'm still overwhelmed by the warm gesture shown by Professor H.P. Tang sir and other faculty members during my visit. Thank you very much, sir. And now moving on to the today's lecture. And as you know that the title of today's lecture is Advances in Diagnosis of Ophthalmic Affections in Dogs. So before starting, I would just like to brief that as we all know that veterinary ophthalmology is just an emerging branch of veterinary science. But however, in India, it is still in fancy, and many of the small practitioners are having sparse knowledge regarding the basic steps for eye examination and various other diagnostic procedures of ocular affections. And now, as we know that now the owners have become techno savvy and they are well versed with the net and other technologies available with them, and they are aware about the diagnosis and treatment options available. And thus, you will see that many times the pet owners are consulting to the practicing vets with more advanced queries regarding the ophthalmological affections in their pets. And at this situation, if a veterinarian is not well versed with the ophthalmic diagnostic procedures, with the advanced ophthalmic diagnostic procedure, then the condition becomes very awkward. The owner is asking many questions, and if we are not able to answer, then it doesn't look good. So it is compulsory for the veterinary practitioners to keep themselves updated regarding the advanced diagnostic techniques for diagnosis of ophthalmic affections in dogs. So I will start with the ease of ophthalmic diagnostic procedure. I always start my lecture, and I always used to tell that eye is an organ that lend itself readily for the diagnostic procedures, and ophthalmic diagnosis is often made at the time of examination. And because most of the ocular structures, they can be visualized either directly or by indirect method without the aid of any sophisticated instrumentation. And eye itself lend itself to non-invasive and many non-invasive diagnostic procedures that can be performed in routine examination. And then many times owner is coming with a pet, you will see that most of the time the following complaints are being presented by the owner, that either the dog is having a decreased vision, or that is completely blind, or it might be having ocular discharges, and there might be ocular color changes. Then there might be pain. Okay, the pain is exhibited by many of the symptoms in the eye that will be discussed in the coming slides. Then opacity or film over the eye, then pupillary changes might be there, noticed by the owner. Then exophthalmos or enlarged eyes. And these are the complaints that form the basis for the problem-oriented approach to ophthalmology. So we have to move our diagnosis keeping in mind what the owner has complained about. Then I have divided this presentation in mainly three components: the diagnosis by neuro-ophthalmic examinations, then diagnosis by basic imaging system, and diagnosis by advanced imaging system. And components of the minimum ophthalmic database for diagnosis of any ophthalmic affections. They starts with gross examination. Then, as I have told, the neuro-ophthalmic examination or visual function test. And besides these, in some cases, advanced imaging modalities such as ocular ultrasonography, then electroretinography, and then computed tomography, MRI, and nowadays scanning laser polarimetry and optical coherence tomography are also being employed to reach at a definitive diagnosis. And many times some additional diagnostic tests like corneal cytology, corneal or conjunctival cytology, and culture and sensitivity are also being used. So diagnosis by ophthalmic test. So examination, whenever you start the examination, we should follow a systematic approach for the ophthalmic examinations, and that starts from outside to inside. So we start from the eyelids. We start from the eyelids to the inside and move up to the fundus. And we have to make this systematic approach that we should not miss anything between these things, from outside to inside. Now, both the eyes and their adnexa should also be examined. And most ophthalmic examinations are best performed in minimally restrained, conscious, and non-sedated animals. That means we do not need to sedate the animal for every routine procedure. And the routine of neuro-ophthalmic examinations, as listed, you can see in the slide, are starts from gross examination, then comes Meniere's response test, then obstacle course test, then corneal reflex test, then pupillary light reflex test, cinema tear test, and fluorescent dye test. We will discuss these in the coming slides. Now, in gross examination, you do not need any specialized instrument for gross examination. Simply from a distance or just coming close to the eye of the animal, we can record if there is any discharge from the eye. Either discharge is either clear discharge or it is a mucoid ocular discharge. Here in this picture you can see. Then after discharge you can move a little closer to the dog's eye, and you can appreciate the conjunctiva. Either it is a clear conjunctiva, you can see here the conjunctiva is very much clear, and if there is any vascularization of conjunctiva, there are many conditions and many affections that leads to vascularization of the conjunctiva, and vascularization can further be subclassified into scleral conjunctival vascularization, or if there is a deep vascularization, then it could be scleral vascularization that comes with the practice, and we will discuss in the coming slides. Then comes, you can examine for clarity of the cornea, and excuse me. So, sorry for the interruption. Then clarity of cornea. Now you can see in these pictures that this, as you are looking into the eye, you can see if there is any focal corneal opacity, as it can be seen here. Then comes that if the complete cornea is hazy, having with the blood vessels reaching up to the cornea, these are known as ghost vessels. And here you can see a clear cornea. How does I say it, a clear cornea? Because beyond it, I am able to see the cataractous lens, clearly cataractous lens in this eye. So you can appreciate the clarity of the cornea. Then in these images, you can see many kinds of affections. All these pictures have been presented to, have been taken from the animals that have been presented to our clinic at the college. And you can appreciate that just by looking into the eye and taking some pictures with your mobile that we are having in our pocket, you can clearly at least have a gross examination diagnosis of the eye or the element of the ocular affections. Here you can see a case of cherry eye, but from looking just from a distance, the cherry eye is visible, but you will not be able to see this corneal ulcer until unless I get a photograph and zoom it to look, or I have to examine it from a near with the ophthalmoscope. Here again, you can see the ulcerative cornea, and here you can see a descemental seal, the iris protruding out. Again, the iris protruding out and a completely damaged cornea in KCS. Then you can see the pigmentary keratitis. Here you can see the scleral hemorrhage, traumatic scleral hemorrhage, and again here you can see a growth, though it is onto the cornea, but it is a squamous cell carcinoma of the cornea. Then again in these pictures, you can see the exophthalmos in the pug. Then here you can see the heterochromia. This is a normal position in huskies. Normal affection, you can't say affection, normal condition in the huskies, Siberian huskies. And this is again a traumatic scleral injury. You can see a dermoid, limboscleral, corneoscleral dermoid is there. And you can see the haziness of cornea and a clear cataractous lens beyond the cornea. Then you can see the scleral congestion in these two eyes. And here in this pic, by gross examination only, you can see that this eye has been operated and intraocular lens has been implanted, and there is adhesion over of the sclera. This is known as anterior posterior synetia of the iris with the lens. Again, these are some pictures. Here you can see the tumors of the eyelids. Then this dog was having some systemic affections, leukemia. This was suffering from leukemia, and these are the ocular manifestations of leukemia. And but at the gross examination, at least you can appreciate what the condition of the eye, and then you can correlate it with the other systemic disorders by further examinations. Here you can see the there is some severe blepharospasm in this eye, and again a corneal ulcer and exophthalmia is there in this picture. So this is what I wanted to tell, that by gross examination alone, you can reach up to the diagnosis in many of the cases, many of the affections. But to reach at a definitive diagnosis, whenever you just diagnose it, any ocular affections by gross examination, always perform the complete examination diagnostic, always follow the complete protocol as mentioned in the previous slides. Then when we move on to the closer to the eye and we have a close examination of the adnexa, then you can appreciate that there is ectopic cilia and diastasia. That means the two layers of the eyelashes that are causing injury to the eyeball and cornea and leading to corneal opacity. Then you can appreciate the masses and other anatomical abnormalities such as entropion, ectropion, and legophthalmosis can also be seen by a close examination. Then conjunctival hyperemia or chemosis as well as some follicle formation can also be seen by close examination. And many times by examining the lower conjunctival fornix, you can see that there is accumulation of some discharges. Then it comes for the Menas reflex test. Then this is a simple test. Actually, you do not need, again, you do not need any instrument, ophthalmic instrument for conducting this. But before, I always say that before going for Menas reflex test, you should always establish that the dog is having a normal blink response, because there are many conditions that will affect the blinking capacity of the eyelids of the dog. So you have to establish that yes, the dog is having normal blinking response, and now you can perform the Menas test. And it is very simple. You just move your hand towards the eye of the dog as if you are going to slap the dog. And if the dog is having vision, then surely it will move away his head from your hand, and will blink the eye and try to escape from your slap. But you should take care that while making this menacing gesture, you should not create an air current, because even if the dog is blind, and even if the dog is blind, but the air current will provoke the dog to blink the eye, and this will give a false Menas reflex test. Then the normal results, if you see if it is blinking, that means there is the sensory pathways are intact, the trigeminal nerve is functioning, and the motor pathway of facial nerve is also functioning. And if it is not blinking the eye even after moving your hand towards the head, then that means that there is some abnormality that indicates poor sensation, or more commonly facial nerve paralysis could be there. Now, this reflex test is particularly used to evaluate the optic nerve, that is second cranial nerve, and the facial and abducens nerve, that is sixth and seventh nerve, are also examined by this. Now, the second is obstacle course test, and now obstacle course test should always be performed in a place to which the dog is not familiar, because dogs are having this capacity, or having this sense that in a familiar place it is very difficult for the owner or for the examiner to diagnose whether the dog is blind or not, because if the dog is familiar with that place, he will avoid all the obstacles. So better always perform this in some unfamiliar place, or if you are examining the dog at its familiar place, then always keep some obstacles in the pathway, and then you will be getting good results. And for evaluation, you will see that you have to examine the dog in both dim and bright light. And if the animal is having a visual deficit and not having a proper vision, then it will fail in the obstacle test, and that can be exhibited by altered gait, or simply the animal will refuse to move. I think there is one video in the next slide that shows how the dog fails in the obstacle course test. Yes, it is a video, and let's see if it works. So in this video, you will see that we have closed the functional eye of the dog, and it was having a traumatic eye. In the right eye, the dog was traumatized, and we were suspecting that this dog is blind. and we just put a bandage over the left eye, and we examine the obstacle course that this dog failed. I think you will be able to see this video. I think this video will work. Hope you can see this video. You can see this dog is walking with very caution. He's very cautious because the place is very unfamiliar to him. And you see how it is stepping. And he will bump to the objects coming in his way. He just move ahead by smelling and by just sensing anything in his way. And you can see how cautiously the dog is moving. See his steps, see his gait, very accentuated gait. You can see this. Yes, he is bumping, and he is not able to see by this eye. You see, bumping with the Almira. So simple test, this can be performed, and it should be performed with every suspected vision deficit eye. Then comes corneal reflex test. Again, it's a simple test, and it can be performed just by touching a thin wisp of cotton while holding the eyelids open apart, and try to touch the wisp at the periphery and away from the visual axis of the dog. Because if the dog is having vision and you are bringing anything towards the cornea from the visual axis, from the middle of the axis, then again the dog will blink his eye, and this will give you a false reflex test. And this test is used to assess the fifth cranial nerve, trigeminal nerve, and the sixth and seventh cranial nerves, afferent base. Then very simple test can be performed, and if the cornea is having sensitivity, then the dog will blink his eye. Then comes the PLR. PLR is a very important examination diagnostic test, and the evaluation of PLR is very important. For evaluating PLR, we would have to have a thorough knowledge of how the vision is formed and what are the other cells or other structures that are responsible for bringing up to the vision. Now, PLR is simple. That means pupillary light reflex. That means constriction of the pupil in response to a light shown over to the eye of the animal. And the important thing is that usually you will see that if there is some problem with the iris sphincters, like iris sphincter atrophy is there, if there is posterior synetia, and in these two affections, that is iris sphincter atrophy and posterior synetia, even if the dog is able to see, even if the dog is having a sensitive retina, and then the dog will not respond to the light. That means the pupil will may also be dilated in these conditions, because the iris sphincter is not functioning. And in cases of SARD, sudden acquired retinal degeneration, you will see that the retina is not functioning, and if retina is not functioning, then the pupil will not respond to the light. Then in cases of cataract, then in cases of optic nerve injuries, then oculomotor nerve damages to the brainstem lesions such as tumors, and some medications like barbiturates, they can also affect the pupillary light reflex test. And in some of these, actually, this test is particularly for the examination of the retina, if the retina is functioning or not. But in cases, it is said that it is the subcortical test. And if it, you say that, okay, the dog is able to see, the dog is having vision, but even then the pupillary light reflex test is failed, then you can say that there is some problem beyond the retina. There could be some problem beyond the retina. So before evaluating the PLR, you have to have a thorough knowledge of the structures. Then comes Sirmer and tear test. Then this is a very important test, and you will see that it should be performed before applying any topical anesthesia. Tear test should be applied so to have a vessel and reflexive status of the tears produced in the eye. And this type of tear strips are readily available in the market. They can be purchased, and this strip is having a notch at the measurement of level of 5. You can see here. Then you have to bend this. Here you can see the notch. You have to bend it and put in the lower conjunctival fornix for 1 minute in the mediolateral to lateral third, then for the 1 minute, and after 1 minute you have to record the wettings, and the dye over the strip will show the markings, and you have to record it. Usually a marking of 15 to 25 mm per minute is shown to be a normal range in dogs, and a marking of 10 to 14 mm per minute will show some low tear production. And if it is below 10, then you can say that yes, the tear production is inadequate, and now the dog is moving towards keratoconjunctivitis sicca, that means dry eye. So this is alarming, and you have to take care and treat the animal accordingly. Next one is fluorescent dye test, and again this test is performed for the purpose of evaluating the ulcers and epithelial defects in the cornea. The fluorescent sodium dye is impregnated on this strip, and this is moistened with the sterile saline and then placed in palpebral fissure. And after 5 minutes, the strip is removed and the excess stain is washed out. Here you can see the stain. Here in this slide, you can see that the excess stain is washed out. And if it is having any injury into the cornea, then you will see this kind of dye is retained in this injury, and this is the stained corneal ulcer. You can see here this type of dye is readily available in the market. And if it is having a clear cornea, a normal cornea without any damage over the epithelium, then you will see this kind of cornea. The important thing is that this dye will stain only to the epithelium and not to the stroma and not to the endothelium. Okay. Now, if it is beyond the endothelium, the corneal ulcer is beyond the endothelium, then you can use another dyes are available, like rose Bengal dye can also be used. Then moving on to some advanced ophthalmic examinations, like slit lamp by microscopy, tonometry, gonioscopic examinations, ophthalmoscopy, nasolacrimal duct patency, and cytological, bacteriological, mycological functions. I always say that, if Even nowadays, we have moved on to these advanced diagnostic techniques, but still the basic diagnostic techniques like Minas reflex, we have discussed in the previous slide, Minas, PLR, then corneal reflex test. They all should be performed in a routine manner. Never skip these tests and never rely simply onto these advanced ophthalmic examination techniques. But you have to always make a combination of the basic diagnostic techniques and these advanced diagnostic techniques to reach at a definitive diagnostic of the ocular affections. We will discuss these in the coming slides one by one. So first of all, we will discuss about the ophthalmic slit lamp examination. And this slit lamp by microscope is used to examine the anterior segment and adnexa, and it provides higher magnifications, that is at least 10 times more than the normal, with the bright focused illumination is there. You can see here a light source is there, bright focus, and this is the microscope, by microscope, and this is the light source, and producing the slit. Then choice is, the slit of the choice can be made and can be fixed, and we can examine the optical section of transparent structures such as the cornea, the aqueous humor, the lens, and the anterior vitreous. Actually, this helps in determining the depth of ulcer or any abrasion or any corneal dystrophies, and provides an oblique illumination that helps in examination of cornea and eye for any minute abrasion or any ulcer onto the cornea. And this allows location of the depth of the lesion and allows visualization of mild changes that cannot be seen with the full illumination. And again, it is commonly used in human beings, and nowadays it is also being used commonly into the veterinary. The important thing is this, that we need a handheld microscope, and as contemporary to the human ophthalmology, you have seen that they are having a desktop all-in-one instrument that can be used as slit lamp by microscope, that can be used as tonometer, that can be used as fundus camera. All the things are centralized in one instrument, but we have to use this handheld slit by microscope, as our patient is not going to cooperate and keep his chin over to the instrument, and moreover the muzzle will cause, and you can see that this will cause the problem in having the examination with the desktop. Then comes tonometry. Then it is performed to measure the intraocular pressure of the eye, and various methods of doing tonometry are indentation and applanation. And nowadays we are using rebound tonometers, and non-contact tonometry is also being done here. And the normal values for a dog's eye for intraocular pressure are 15 to 25 mm of mercury. And you know that it is essential to go for tonometry in cases of glaucoma. But however, it is also very helpful in diagnosing and management of cases of uveitis. Uveitis, in case of uveitis, you will have a decreased intraocular pressure in the anterior segment, then contemporary to the glaucoma, where the intraocular pressure is increased. So always go for a tonometry and look Even don't always look for the increased intraocular pressure. Many times you will see that intraocular pressure is below the 15 mm of Hg. That means that is also alarming. And if it is 15, then you have to further go for some other diagnostic aids to rule out the case of uveitis. And in the coming slide, I think we will be able to see that this is the indentation tonometry, how it is performed. You can see the normal Sears tonometer, the standard Sears tonometer that is being used in routine ways. And nowadays it has been replaced by the tonopens coming. I will show in the coming slide. Here you can see how the indentation works. After putting the weight, and the cornea is giving one indentation, and the level of indentation is measured over the scale in the Sears tonometer. And in case of the now readily available rebound tonometers are also there, you can see, and tonopens are also available that can be used as indentation tonometer. And in rebound tonometry, we are having impact of dynamic tonometers. They just touch to the cornea and come back, and the distance or the time taken for touching the cornea and coming back is evaluated as the intraocular pressure. And here you can see a small probe is there that is readily and electromagnetically propelled from a fixed distance to the cornea, and that contacts the cornea before returning to the instruments. And eye with higher ocular pressure, then if eye is having a more increased intraocular pressure, that means the distance of touching to the cornea, between the cornea and the instrument, will be shorter, and time will also be shorter, and thus the measuring the intraocular pressure. Now, this kind of non-contact tonometry is also being used, at least we are using at our center, and we found that this is more of a simpler way to measure the intraocular pressure, and this does not have any contact with the cornea for measuring the intraocular pressure. This simply releases a puff of air. Air puff is released and is thrown over to the cornea, and the readings are shown over here on this screen. And as you will come close to the cornea at from about 12 mm, 12 centimeter of distance, then you will see that this type of plus sign is shown in the center. And when it comes in the center, automatically a puff of air will be released and the intraocular pressure will be shown onto the screen. So I think this is more of a easier device, and you need not to have contact with the cornea. You need not to put any anesthetic drops as they are required in case of tonometers, or that rebound tonometers also you have to put some anesthetic drops, but in here you need not to put any anesthetic drop. Then again, this gonioscopic examination is there, and you can see that gonioscopy, when it is particularly of the use in case of glaucoma, and can be used in conjunction with a slit lamp or operating microscope to gain the view of iridocorneal angle. You can see here, this is the iridocorneal angle, that is the drainage site of the fluid in the aqueous fluid, and continuously secreting and draining through the iridocorneal angle. Any defect in this iridocorneal angle will lead to increase in intraocular pressure, and this iridocorneal angle can be affected by the tumors, cysts, or any foreign bodies can be there, or this gonioscopic lens can also be used for detection of foreign bodies or tumors or exudates in the iridocorneal angle. And again, in case of glaucoma, it is being used, and it is not a simple technique to expertise. The learning curve is, it's very difficult to go for gonioscopy. If you are not doing it in routine, it cannot be performed. It needs a lots of practice to keep the gonioscopic lens onto the cornea and then to examine it by slit lamp, by microscope and other ophthalmoscopes. So you need a lot of practice, so lot of routine use. Now, this is something you can use in a routine way. This ophthalmoscopy can be used in a routine way, and you can see that by using a simple ophthalmoscope, you can examine many of these affections like anisocoria, absence of tapetal reflexes could be diagnosed. Then nuclear sclerosis and cataract can be readily differentiated by having a ophthalmoscopic examination, and then focal opacities can be traced out using ophthalmoscope. Then aphakic crescents. Aphakic crescents, what are aphakic crescents? When the lens is luxated, having slight luxations, it can be easily seen. Here you can see in this picture, you can see this is the aphakic crescent. The lens is slightly luxated medially, and then strabismus can also be diagnosed with the ophthalmoscopy. Now here you can see the ophthalmoscopy is usually of two types: direct ophthalmoscopy and indirect ophthalmoscopy. In direct ophthalmoscopy, you will see that this type of ophthalmoscope is available, I think, in every clinic. And if not, all those who want to establish a ophthalmic clinic or start ophthalmology should at least have this basic instrument, which is very essential for ophthalmological examinations. And it's a very simple instrument. It is having a power source and a halogen and xenon coaxial optical system is there, and light is directed via a mirror, or you can see from here a prism into the patient's eye, and is reflected back through a lens viewing window in the ophthalmoscope to the examiner. And the image that the examiner will see will be real, erect, and it will be a magnified image. Many times magnified image could be seen, and those who will first time handle the ophthalmoscope, at least first of all, they will have to on and off the switch. So this is the on and off switch, and it is not that you have to just press it. You have to rotate it for making it on and off. And there are two diopter dials. Diopter dial and aperture dials are there. By this you can make the different types of aperture, and even you can dial the different diopter lenses can be fixed for viewing from the cornea to the fundus. Different types of diopter are used. That say, for example, when you are viewing to the cornea, you have to use a plus 20 diopter lens. You have to fix, you have to dial it by the diopter. Then you can see here, as I have told previously, that it contains lens of varying diopters through which the examination can be conducted. And here at this point, you can see the number of diopter from which you are viewing. And usually most of the ophthalmoscope are having two color numbers for the diopters, blue and red. Usually the red represents a negative diopter from -1 to -3, and a blue shows the positive diopter from 1 to 20 diopter usually. And for anterior segment, to examine the anterior segment, you have to fix the diopter lens between 12 to plus 20, and for observing the lens, you have to set the diopter at +8 to 12, and for vitreous humor, you have to dial it to 0 to +8. And for as we move on backward towards the retina, towards the optic disc, you have to make it at -3 or less to view the. And also it depends upon the vision status and the power status of the examiner's eye. Here you can see how the ophthalmoscope is being used in. You have to, you need not to have any assistant to keep the eyelids open. By one hand, you have to keep the eyelids open, and by another hand, you hold the ophthalmoscope and examine the eye. Now, something very important that I would like to tell here is that always start practicing ophthalmoscopy from one arm's distance. I always say, always keep one arm's distance. As nowadays, you know, in Corona, we are using one dialogue, "Do gaj ki duri hai zaruri." Similarly, in ophthalmoscopy, when you are starting, at least ek gaj ki duri to zaruri hai hi hai. At least you have to keep your hand at ophthalmoscope and dog's eye at one arm distance, and from there you have to first of all see the tapetum, and if your light focusing on the light on the eye and you can focus the tapetum, then you have to move nearer to the, always try to move slowly towards the cornea, and as you move towards the cornea, always adjust the diopter with your finger, with your index finger, and as you come closer to the cornea, you come, if as you want moving towards the retina, come very much closer to the cornea, and you should be very close as you can say, just about 4 to 5 mm, just touching to the cornea and looking to the fundus. So it is a matter of practice. You have to practice, and I always tell to the beginners that if you want to have a good ophthalmoscopic examination, you should examine hundreds of eyes. Start examining the eyes, healthy eyes, and after examining the 100 healthy eyes, whenever you will examine affected eye, then you will realize the difference between the healthier and the affected eye. So always examine the healthier eyes. Whenever any dog is presented for the ailments, you can examine his or eyes. Now here you can see indirect ophthalmoscopy. In indirect ophthalmoscopy, the advantage is this, that we have a larger area for visualization. However, the magnification is not of that level as we get in direct ophthalmoscopy, but yes, it is quite helpful in examining if we want to have a larger area of visualization. And moreover, I find it more suitable in case of fractious dogs, when you suspect that yes, dog is not going to cooperate and he may injure you, then you can use this indirect ophthalmoscope. And again, the image is small and inverted image is seen. And for this, you need a condensing lens of about 20 diopter between your eyepiece and the eye of the dog. And this is the headpiece kept over the head, and you have to adjust the eyepieces as focus, make a focus, and then use this condensing lens of about 20 diopter, and a better, larger area of visualization is seen. Then after this ophthalmoscopy, you can check for some nasolacrimal duct patency. Many ocular affections will be diagnosed by this nasolacrimal duct patency. And I would like to say that this nasolacrimal duct patency, in case of when you are performing the seminal tear test, when you are performing the seminal tear test and you see that fluorescent dye test, and you see that the stain is not seen at the muzzle. Particularly, what happens whenever we put this fluorescent strip in this fornix, there is one puncta in the lower eyelid, and the stain will move through the nasolacrimal sac and nasolacrimal duct onto the opening at the nostril level. And if the stain is there, you can be assured, like here you can see the stain, you can be sure that yes, okay, nasolacrimal duct is patency is there. But if you do not see, then instantly we cannot say okay, it is blocked. But other clinical symptoms could also be there. Say for example, if you are having a normal serum tear test values, and even then there is a continuous lacrimation from the eyelids, that means although the tear production is of the normal level, but it is not flushing out through the nasolacrimal system, and in that case you have to put one cannula into the nasolacrimal puncta and flush some normal saline or some stain through this. And if it is coming to the nostril, then it is okay. But in many cases, if it is having a blockade, then you have to treat it accordingly. Now, other cytological and bacteriological examinations, as I told previously also, that these are some instruments. They, although this is not used in a routine manner, but it can be performed after the initial examination and before performing the additional diagnostic test. After when you performed all these ophthalmoscopy and all these examination, then you can go for this. Then topical anesthetics should not be used as they are bactericidal. So these scrapings or the cytological sample should be taken before the use of any topical anesthetic agent, and culture and sensitivity testing is most useful for in cases of septic corneal ulcers. There are the ulcers that will show the bacteriological growth is there, and you have to use a particular type of antibiotic. Then you have to use this cytological or bacteriological antibiotic sensitivity test also. Now, my friend over here, and if you can take a break, have a sip of water.
Wadru aja takut. Amat sudah wadrun getun gan.
Baker sir, am I audible? Hello.
Yes, sir. Yes, sir.
Yes,
sir. I'm getting many kinds of voices. I think some of the attendees are having their microphone on.
Yes, sir.
Request participants to mute their microphone.
Mr. Himanshu Parmar, please mute your mic.
Please mute all the microphones. Otherwise, they are causing disturbance.
Mr. Himanshu Parmar.
Pinch ada vocal.
There is a lot of noise.
का नंबर नहीं
Okay. Then let's continue. So now moving on to some more imaging system. Until now we have discussed regarding the normal routine ophthalmological examinations and routine procedures. But from here onwards, we will switch over to the advanced and some advanced techniques, imaging techniques that might many ophthalmologists or many veterinarians will feel that they are of high technology being used, because these are not in routine use. I'm telling you, these are not being routinely used in veterinary field, although they are of routine use in medical science. And whenever any of us visited an ophthalmologist, you can have a view of any of these techniques. They are being routinely used in human beings, and we are charging high for these techniques. But in veterinary field, we are costing a lot to establish all these machines for this advanced imaging system. But although they are not being used in routine, but I would like to elaborate this and discuss these, as we should have at least the basic knowledge, theoretical knowledge regarding these techniques, how these techniques are formed, and for how used. So whenever we get a used in. So these advanced techniques are ophthalmic ultrasonography, simple ultrasonography is there. In the coming slides. Then electroretinography. This is something that I think have become a common practice in veterinary also. Initially, as far as I know, it was started at Anand. Patil sir established this electroretinography at Anand, and after that we followed them. And at Bikaner, we also started doing electroretinography. Then MRI, patchimetry, scanning laser polarimetry, OCT, fluorescent angiography, all these are not of routine practice. Although we are at many centers having fundus cameras, and that can be used for fundus photography and can be used in routine way. So first of all, let's discuss regarding the ocular ultrasonography. Basically, two types of ocular ultrasonography is being performed, A mode and B mode ultrasonography. And in A mode, also known as amplitude mode, it is the most original of all ultrasound methods, and you will find that even today and in human ophthalmology, they are commonly using this A mode ultrasonographies. And here in these echoes are received by the transducer and are displaced one-dimensionally in one-time dependent manner as vertical spikes. Amplitude from a base, you will get just a ECG type of lines, and I will show in the coming slide. And the height of the spike shows the intensity of the echo, and the distance between spikes depends on the time required for the ultrasound wave to reach a given acoustic interface. And you will be seeing here you can see the different types of probes that are being used for A mode ultrasonography, and this is the tissue model for calibration. Before before performing any A mode ultrasonography, the probe is placed on this and calibrated accordingly. And here you can see the vertical axial scan. A scan is being made in the dog, and after this you will see that this kind of images can be seen. This kind of echogram of the canine eye can be received in the A mode ultrasonography. Then very common is B mode ultrasonography that most of us are using, and it is easy to learn also. Like other ultrasonography of abdomen, you can also expertise in B mode ultrasonography of the ocular affections. And in this, the echoes are displaced two-dimensionally as light dots of different intensity, and brightness on the screen. And most of us are, I think, used to use this B mode ultrasonography machine, and it is most commonly used method for evaluation of intraocular and orbital lesions in veterinary ophthalmology. And again, a transducer of 5 to 14 megahertz can be used to produce the detailed image of the eye. And the good thing is that you need not to sedate the dog for performing the ocular examinations, and it can be easily performed with the dog awake. And a sterile water-soluble lubricating acoustic gel is used as a coupling gel between the probe and the cornea. That use an acoustic window, and no pre-examination drug or medication is required, and patient's eye are held open, and eyelids are held open manually by the restrainer. And here you can see in the position of the dog, you can keep it in the lateral position, and eyelids are kept apart manually, and the probe is placed here onto the eye, and this can be performed transcorneal, that is, the probe is directly kept onto the cornea, and in some affections where the cornea is having some injury, or it is risky to touch the cornea, in that cases even it can be performed transpalpebral. That means even the eyelids can be kept closed and it can be performed. You can perform the ultrasonography. Here you can see the different type of probes. Different machines will be having different types of probes, but a probe of at least 5 to 14 megahertz can be used for the B mode ultrasonography. And here again you can see different types of probes are being used in different centers with different machines. And ultimately you in B mode, ultimately you will get this kind of image. Now to understand, you have to go a little, you have to read a little theory about the ultrasonography. Here as I will tell you that, okay, this is the ultrasonographic image that shows the outermost layer, slightly hyperechoic layer. You can see here, this is the cornea, the two layer of the cornea. Then between the cornea and the anterior capsule, this is the anterior capsule of the lens. Then this is known, this is the aqueous chamber. You can see the anechoic space between the slightly hyperechoic pictures of anterior lens capsule and the cornea. Between these is the aqueous chamber or aqueous humor. Then you can see these are the this is the anterior capsule and this is the posterior capsule. So in between is the normal lens. Usually a normal healthy lens will appear as anechoic. And in the evening session, I will tell how does a cataractous eye looks on ultrasonography. Then this is, you can see the ciliary apparatus, ciliary bodies. And beyond the posterior lens up to the orbital rim is the vitreous humor. Beyond from the posterior lens to the orbital rim, you can see here that this is the space for optic nerve passage in the orbit. Optic disc, you can see optic passage, and this is the aqueous, vitreous humor having anechoic image. Okay, so this type of image you have to look for the normal ultrasonogram of a dog. Then you will be able to see many kinds of differences in ultrasonogram. If there is any tumor or any hemorrhage in the vitreous or in aqueous, if there is any hypema is there, if there is any kind of pus, you can easily differentiate between the ultrasonographic images. And again, in this image, you can see a normal B mode and a vector A echogram of the canine eye. You can see here, normal, it is a normal echogram. And in case of anterior segment lesions, you can see the neoplasia or neoplastic lesions that are usually presented as a circumscribed eco-dense mass like structures, and they usually arise from the iris and ciliary body and may invade the anterior chamber or vitreous, causing lens luxation or subluxation. I think you can see here the lens has been luxated. It is the posterior capsule of the lens. You can see the lens has been luxated, and the ciliary body tumor. This is the ciliary body tumor invading the vitreous. It has invaded the vitreous and displaced the lens and caused the lens luxation. So before making this kind of diagnosis, you need to have a thorough ultrasonographic image knowledge. Then lens abnormalities like nuclear sclerosis or cataract formation can also be diagnosed by this ultrasonography, and it can be USG can be performed as a pre-operative process, evaluation process for cataract surgery, and for even for diagnosis of retinal detachment. You see, many times while performing cataract surgeries, you will see that okay, everything is okay, even then the dog is not having vision, retain the vision. So you have to make sure that okay, the retina is okay. For this purpose, you can go for USG, and another good instrument we are having is electroretinography. It can also be done. And posterior segment, again, these posterior segment lesions, you will get, if it is a normal eye, then you will see a homogeneous black area on B mode and a horizontal flat line on A modes. And if in case of pathological changes, as I have told you, in case of vitreous, that having hemorrhage or inflammation or membrane formation, or any kind of degeneration or any kind of embryological remnants, if are there, then they can also be diagnosed by this. And a complete, as I have told you, retinal detachment can easily be seen with the ultrasonograph, and a Seagull effect is usually seen. I think in the coming slide you will see that. Here you can see the large vitreous cyst in sagittal section. Here you can see a vitreous cyst is there, and in this sonogram you can see a seagull. Seagull is a bird, I think all of you know. Then you can see that the retina is completely detached, that the position of the normal retina is over the orbital rim, over the choroid, and now you can see that it is detached only from here. It is attached, and from both the sides it is detached. So it can be easily diagnosed by the B mode ultrasonography. And beyond this, most orbital lesions like neoplasia, abscesses, they can also be seen by this, and abscesses can be identified as a cyst-like well circumscribed area of very low internal reflectivity. They can be diagnosed easily unless you don't have a regular ocular ultrasonography facility. You will not be able to diagnose. For this, you have to expertise. Here you can see the thickened scleral area with an overlaying choroidal detachment is there. You can see here the choroidal detachment is there. And globe rupture, ultrasound of globe rupture, it can be seen here. So I have kept this foreign body in the eye. So just to give a glimpse of what kind of affections that can be easily diagnosed by the ultrasonography, I have kept these slides. Here again, tumor at the back of the eye, you can see at the orbital rim. You can see this tumor here. And now moving on to the electroretinography, that is very important to establish the functional utility or the function of the retina. Here you can see how the handheld multi-species electroretinography system, HMS ERD system, we are using at our center. And I tell you, once you expertise in this electroretinography, it is very helpful tool for you in a routine manner to diagnose many of the ocular affections that causes vision deficit. Say, for example, in cases simply if you get a case of sudden blindness in dogs, sudden blindness is usually shown in sudden acquired retinal degeneration or this, then okay, the dog is as per the owner, the dog is blind. But if you are having this facility at your center, you can easily tell, okay, either the rods are gone or the cones are gone. Now, to this electroretinography will differentiate between the status of the functional rods and as well as the cones. So you can tell the owner, okay, this dog is having vision deficit at night or in the daylight, and he will agree with you if you are well versed with the electroencephalography and you see that okay, the cones rods are not working properly and the wave showing the roads is not of usual manner, then you can ask the owner, yes, this dog is having some problem in the night vision or in the daylight. And this, as per the instrumentation, you can see here, this is simple, not much of the instruments are needed, and only this is routine eye speculum to keep the eyelids apart. Then this is active electrode. This is having a coupling type of structure, and that is kept over to the cornea after keeping the viscoelastic drop between the instrument and the electrode and the cornea. And these are two electrodes that are used as reference electrode and ground electrode. And this is the simple ERG machine, or you can say the amplifier, that amplifies the responses received from the retina. I will show in the coming slide how they are placed. Here you can see in this that this is the amplifier at place, and this is the ground electrode, and just keep over the forehead. And the another electrode, that is the reference electrode, is always put over to the eye that is being examined. Say, for example, if this eye is examined, you have to put the electrode at somewhere between the ear and the lateral canthus. And again, the active electrode is kept over to the cornea of the eye that is being examined. And this is the Bonsfield stimulator that put the flashlights on. This is the LED that gives the light, and this produces the light. And this is shown over to the cornea, and the responses are recorded, amplified by this, and recorded onto this laptop screen, and you can also print them. So normal electroretinography of a dog, if once you start reading this, you will see that there are two waves, A and B waves, and A wave shows the amplitude. It is measured from the base of the A wave trough, and the B wave amplitude was measured from the A wave trough to the B wave peak. So this is the amplitude, and A by B amplitude implicit time was measured from the stimulus onset to the A wave trough and B wave peak respectively. So ultimately what you have to see is this, that okay, this type of normal electroretinogram is received in case of normal eye. Whenever there is any problem with the photoreceptor cells in the eye, you will not get this normal graph, electroretinograph, and you will get somewhat this. This is the norm. Again, the normal. You can see here A wave. This is B wave, and again the C wave of the stimulus. And in cases where there is any kind of problem with the photoreceptor cells, a straight line will be received in case of degenerated retina. In case of sudden acquired retinal degeneration, we get a straight line. That means the retina is gone and now nothing can be done. Now, moving on to the next advanced diagnostic technique. This is MRI, and although being performed in human beings, and in MRI scanning, the intravenous paramagnetic agents, contrast agents such as this DTPA, this can be used to enhance the appearance of the changes. And contrast enhanced MRI improve visualization of blood vessels, breakdown of the blood-brain barrier, tumors, and inflammation. And generally, the use of contrast enhancement is recommended for case of orbital or neuro-ophthalmic diseases, but it may not be necessary for acute hemorrhage or trauma. Ultimately, MRI will give you a detailed image of the soft tissue or the blood-brain barriers or any kind of inflammation in the soft tissue of the eyeball that can be easily seen by the MRI. Again, this is not of a routine use, but if it is being done at some centers, or you can outsource at the medical people, you can use this. And you can see that this is a reformatted surgical CT image of normal feline globe seen in the soft tissue window. And again, appearance of normal canine globe, you can see here, and dorsal T1 and T2 weighted MRI. Okay, then this is something that has to be learned at basic level. For this, we have to learn the basics of MRI. But okay, just for overview, you can say that this kind of images are received and can be interpreted. Again, MRI showing exophthalmos caused by retrobulbar space occupying lesions. Here you can see the space of occupying lesions are there, mass in a rabbit. And then comes spectrometry. It's of common use in human beings to know the corneal thickness. It is measurement of corneal thickness that includes how it can be performed by ultrasound spectrometry, by confocal microscopy, optical biometry, and optical CT, and optical orange spectrometry can also be performed. And this is, I tell you that require clear corneal reflections. This cornea has to be very much clear, and in cases when cornea is not clear, then it cannot be, patchometry cannot be done. And I suggest that this kind of patchometry is to be routinely performed before doing any case of cataract surgery, because actually the layer of endothelium is plays a very important role in the outcome of the result of cataract surgery. Many times in human beings, whenever you will go for cataract surgery, they will perform patchometry and will tell the owner the outcome of the cataract surgery, that okay, the endothelium layer is very thin, the endothelial cell layer is very less, so there are chances of complete corneal opacity after cataract surgery, and a corneal transplantation may be needed. So similarly, in veterinary field also, if we start performing this patchometry in a routine way, we can tell the owner, and many times we can prognose the cases of the outcome of the cataract surgery. And then comes specular microscopy. This is again to analyze the corneal endothelium thickness. This can be applied to the epithelium stroma as well, and to the lens. And this also again requires a clear cornea. And I think in the coming slide, you can see the picture here, how this is being performed. I think no veterinarian is performing this, but at a medical level, for research level, this is being done. And here you can see a non-contact specular microscopy being undertaken to an anesthetized dog is there, and you can see the specular microscope image of central corneal thickness of a normal 9-month-old dog. And here you can see the normal lens, normal cell density. You can see high cell density of the endothelium. And in this case, if we perform cataract surgery and everything goes well, nothing will happen to the endothelial layer and to the cornea. But here you can see very low density. So this type of cornea are high surgical risk patients, and even if you perform the cataract surgery efficiently, even then there might be some opacity as the endothelial cell is very thin or having low density. Then comes this scanning laser polarimetry, and again you can see that the retinal nerve fiber layer has a birefringent properties due to retinal ganglion cells and neurofilament being highly ordered and in a parallel manner. And in this scanning laser polarimetry, you will get this kind of images. You can see here increased signal on areas corresponding to the chorioretinal atrophy. Here you can see this. So again, this is more of research purpose and performed at higher end instruments, performed with higher end instruments. Then OCT, optical coherence tomography, and it was originally developed to imagine the retina and optic nerve head with the micron scale resolution. And when it is performed, you will see that this type of images are being received at optical coherence tomography with 3D reconstruction image of the fundus. You can see here. And again, you will see that the quantification of the retinal nerve fiber layer thickness also provides an indirect measure of axonal and neuronal loss in the inner retina. And these images compare favorably with the histological studies and allow the identification of individual retinal layer, including the photoreceptor cells. So again, this is more of research purpose and not in routine use, but okay, we should know that yes, it is being performed. And then comes fluorescein angiography. It can also be performed in many centers. Then it provides a means of examining the vascular component of fundus. Okay, you can by having many other diagnostic tools you can examine, but by this angiography you can completely examine the vasculature, iris vasculature, then and many of the vasculature of the fundus. Then sodium fluorescein is injected here, and retina is illuminated with blue light, and images are recorded after fluorescein injection at different levels, at different time zone levels. Here you can see the normal fluorescent image that can be maximum fluorescence can be seen here. Retinal, arterial, venous phase, and different phases are recorded as when the fluorescein reaches to choroidal, then it choroid, then it known as choroidal phase. Then when it travels to the retino anterior capillary venule, then again this phase is recorded, and then a recirculation, third level, a recirculation level is recorded and can be seen. Here you can see the normal canine fluorescein angiogram in the A, then choroidal phase. This is the choroidal phase. Then arteriovenous phase. Arteriovenous phase you can see. Then venous phase. Third one is venous phase, and late phase after the drainage of complete drainage of the fluorescein dye. Now, abnormalities usually seen in the fundus in this angiography are hyperfluorescence can be seen, hypofluorescence can be seen, then pseudofluorescence and autofluorescence, and these are evaluated as per the clinical signs of the dog that have presented to you. You can see here central serous retinography is there, and the image of the central serous retinography. Then microaneurysm, you can see here no dye has been taken up here as this is aneurysm, and retinal vein occlusion, you can see here no dye, retinal vein occlusion is there complete. black images are obtained. Then lastly, we will discuss something about fundus photography. This can be performed with the handheld fundus camera that can be acquired at the veterinary centers. And this image shows the desktop camera. Photography of the normal and diseased ocular fundus can be performed there. Now, different factors are there: quality of the camera, then the corneal distance from the camera, then the restraint, how the animal is restrained. Species variation could be there, pupil size can be a factor in fundus photography. Then ocular media, if we are not having a clear ocular media, that means if the cornea is not clear, the fundus photography will not be possible. Any of the media, that means either aqueous or lens or vitreous, if opacity of any of these, haziness of any of cloudiness of any of these media will affect the fundus photography. And then the film speed, and here you can see the retinal detachment observed in case of fundus photography. You can see here, this is the fundus photo of a dog, and a subretinal hemorrhages. Although I tell you that all these images can be seen by even by the direct ophthalmoscope if you are having a good experience of doing ophthalmoscopy. You can diagnose these subretinal hemorrhages in ophthalmoscopy also. But for you can say that for further reading or for further evaluation, for better evaluation, we need this fundus photography. And you can see the retinal necrosis here, a photo of retinal necrosis, retinal hemorrhage, and a foreign body you can see in the fundus again. And this this type of fundus photography can be expertised and can be used in veterinary centers. Chorioretinal lesions, different chorioretinal lesions. By fundus photography, you can put a proof. Okay, I have seen this chorioretinal lesions on ophthalmoscopy, and by funduscopy, you can give a proof. And lastly, these are some references in previous lecture of Parekh sir. Many of the students were asking regarding some books, so I have put on this slide that these are different books or essentials of veterinary ophthalmology, ocular imaging by David and Donaldson. And beyond this, there is Slater's veterinary ophthalmology that I have not mentioned here, forgot to mention, by Ron Offrey and David Muggs. They are two renowned ophthalmologists. So that book can also have a reference books. So thank you very much. Thank you very much for patience hearing. And thank you, Tank sir and Talekar sir, for giving me this opportunity to deliver this lecture. Thank you very much.
Thank you, Dr. Nirmal. Chairman.
So, thank you, sir. Such a nice presentation.
Video
best information. So definitely, the participant have real lots of things related to this ophthalmic affections. So, if there are any query or doubt, please ask participant.
नीचे देखो लेफ्ट में
PhD student.
PhD student. Sir, our one PhD student is interested in cataractic surgery. So I request him to ask some questions.
I would ask some questions.
No, Dr.
Darshan.
Yeah.
PhD student.
Welcome, sir. You can ask.
So last few slides, he is saying it is not understanding.
Yeah, that before starting the advanced imaging section, I told that these are not these techniques are not routinely used. And for understanding these techniques like MRI, like OCT, you have to go a lot of theoretical portion and again a practical session that even we occasionally get a chance to perform all these theoretical portion because the title was advances. So I just try to include the advanced techniques in my presentation, although they are not being routinely used in the field of veterinary science. And we have also not get a chance to perform OCT, ocular tomography. We have coherence tomography also I have not seen performing, but you can see this. All these pictures are from the books, and just to give you an overview that yes, okay, you can have a further detailed knowledge regarding this from the various books that I have mentioned.
Sir, in your center, you are getting a foldable lens or a foldable lens in very less or cheaper than anywhere. So we are facing a problem to get the foldable lens here. So everybody is, asking for 50,000 or more than 14,000.
Sir, it's not like that. Actually, we have, thanks to Patil sir, we have received this lens from Gujarat itself, from Ahmedabad, a company manufacturing at Ahmedabad, eye care company, that have supplied this intraocular lens, foldable intraocular lens, just costing 2,000 rupees in 2016. But now, when I approached to that company, they tell me that at that time it was supplied under a MOU with Dr. Patil sir, and Dr. Patil sir just tell them to supply lenses, and we procured about 50 to 80 lenses from them at the cost of 2,000. Now they are telling that the price has raised and they are asking up to 14,000 rupees. And again, I am also in search of some cheaper intraocular lenses. I have contacted the persons at Himachal also, and at Ludhiana. They are getting cheaper that about in the range of 2 to 3,000. So as well as I get some contact with the persons, I will let you know, sir. Sure.
Okay, okay. I again request you to resolve this problem because you are regularly doing the cataractic surgery with the foldable lens.
Yes.
So it's very great
Sure,
honor
sure,
for us to get in 2000. Thank you very much, sir.
Sure, sir.
Doctor,
Any more questions?
thank you. Mul.
Questions?
Sir, I have a question, sir.
Please, please.
Please, go ahead.
Sir, myself, Dr. Maharaj. Sir, based on the ERG findings, can we differentiate between retinal detachment and PRA?
Retinal detachment and?
Progressive retinal atrophy or
No.
retinal atrophy.
Listen, Dr. Mehraj. Dr.
Yes,
Mehraj has asked this question.
Yes, sir. Yes, sir.
Dr. Mehraj, actually, electroretinography will simply tell you the status of functional level of photoreceptor cells. Okay. And in both the cases, be it retinal detachment or be it degeneration. Okay, in case of retinal degeneration, there will be no response in case of electroretinography. A straight line will be received. But in cases of retinal detachment, still some part of retina photoreceptor cells are working, and that response will be shown all to the electroretinography. So this is the common difference, that the level of graph you will receive in both will be different. In case of retinal degeneration, you will receive a completely flat line.
But sir, if suppose if there is a complete retinal detachment, is up to ora serrata. So what will be the findings on ERG? Is it same or they are different?
No. If I tell you, actually, in case of detachment, even if it is a complete detachment, it depends upon the time zone. If it is a chronic case, then you see there will be retinal degeneration after detachment. So
Yes.
no response. But in recent cases, even if there is detachment and retinal photoreceptor cells are functional, in little bit receptor cells are functional, they will show a little bit response. Otherwise, there will be same findings with the degeneration and detachment.
Okay, thank you, sir.
Welcome.
Good afternoon, sir. Dr. Shardul Salvi here from Junagadh Surgery Department. Sir, I have a question about Shermer tear test in horses. So, Shermer tear test in horses. So, how to perform it in horses? Because the normal strip is of 40 mm, and if we use the same strip in horses, it will get completely wet. So, are there any commercial strips specifically prepared for horses?
No. Actually, what's your name? Dr. Shardul.
Shardul, yes, sir.
Dr. Shardul, in horses or in cattle, in say for example in large animals. Okay.
Yes.
For how much time you keep the strip?
1 minute.
1 minute. Actually, in many standard books, you will see that you have to keep this strip only for 30 seconds. Okay, reduce the time. And you have to standardize it. And with the reduction of the time, in many of the standard books, you will find that the time is specified only for 30 seconds, because in 1 minute, the strip will be fully wet. Okay, so just compare it with the 30 second and find the level that has been shown for the large animals, for equines, for horses. Different studies have been conducted, and moreover, if every center have to standardize these techniques, in case of equines and in cattle. At your part of area, you might not be having the same environment as we are having. And I tell you, this Sirmer tear test have a great variation. Diurnal variation could be there, seasonal variation could be there, and even other factors, they affect this Sirmer tear test. But even then, if you are performing in equines, then reduce the time to 30 seconds and then see. I hope you will get the better results. Reduce the time. Is it okay, Dr. Shardul? Hello.
Thank you, sir.
Welcome, sir.
Sir, one more question, sir.
Please go ahead.
We find corneal ulcer in cattle in field conditions where no labs or any clinic is available. So, how we can treat such cases?
Corneal ulcer?
Yes, sir.
In large animals?
Yes, sir.
How do you treat the corneal ulcers in small animals?
Sir, autologous serum, antibiotics, then this.
Okay. The same procedure can be used for large animals. The difference is only this, that the pet animals, when you tell a pet owner that, okay, instill these eye drops for 6 times a day, he will instill 6 times a day. Okay. Now, if you tell a cattle owner, he is having other cattle also, he will not care about this. Okay. So better, I always prefer that in case of large animal corneal ulcers, go for tarsorrhaphy. The first thing is go for tarsorrhaphy, temporary tarsorrhaphy, and always tell the owner to administer the eye drops more frequently. At least when you tell him that, okay, put the drops every hourly, then at least he will put the drops of 2 hours or thing. Then autologous serum you can use easily. And the most important thing in case of large animal that I have applied is that you should always debride the cornea. In case of corneal ulcers, there is a necrosed layer of epithelium. In the case of corneal ulcer in cattle, also in dogs it is seen, but more because you will receive a chronic case in cattle. So always debride that corneal ulcer and increase the frequency of installation of ophthalmic drops, anti-inflammatory and analgesic drops, and moreover always try to give a temporary dorsography on there. So
can we perform grid keratectomy?
Pardon?
Grid keratectomy to debride the cornea?
No, I think that is not required in large animals, although this is usually practiced in small animals. Yes, in cases, grid keratotomy is usually can be of use if there is a chronic corneal ulcer, a deep corneal ulcer is there, and in superficially, if there is any superficial ulcer, you need not to go for grid keratotomy. And yes, if you are well versed this technique, you can use. This is a good technique. No problem.
Okay. Okay. Thank you so much, sir.
Welcome.
Good afternoon, sir. Myself, Dr. A.K. Sharma. Good afternoon, Dr. Jiwal.
Good afternoon, sir.
Myself, Dr. A.K. Sharma, Arun Sharma.
Oh, Dr. Arun.
You delivered a very nice presentation.
The person you're calling is not answering. Please try later.
Hello. Hello. Hello.
Hello.
Am I audible? Hello.
Yes, sir. Yes, sir.
Hello, Dr.
Am I
Arun,
audible
how are
to
you?
you, sir?
Hello, Dr. Arun. How are you?
Fine, sir. Fine. Absolutely. I'm absolutely fine, sir.
Oh, that's good.
Sir, we received many questions regarding your presentation.
Yeah.
One of the participant, Dr. Dinesh Qureshi, has asked that what is the rewarding treatment for corneal melanosis?
Corneal melanosis.
What is the rewarding treatment? Oh, yeah.
In dogs, na?
Yeah.
In dogs. Actually, I tell you that corneal melanosis, if once has acquired a portion of cornea, mostly I have seen that it can not be reverted. But yes, it can be prevented. And if it is because of corneal dryness, it can be prevented. And in many drugs like cyclosporins are being used for this corneal melanosis. Although if you keep the eye cornea moist, then the speed of corneal melanosis can be checked. And moreover, if it is in the stromal layer, then some surgeries are also proposed, say for a layer of stromal thickness. In human beings, it is being practiced, and also in some veterinary field, a layer of stromal layer having the melanosis can be removed. But that need a great expertise, and even I have not performed. And simply we try to restrict the corneal melanosis by using these cyclosporins and other drugs that checks the corneal dryness.
Okay, good. I think Dr. Dinesh, you got the answer. One more question.
Yeah.
Participant. It is from Mukesh Patil.
Okay.
So, how we can diagnose rabies case on the basis of ophthalmic investigation?
Rabies?
Yeah. Through ophthalmic investigation. How we can
I do not suggest to go for ophthalmic examinations in case of rabies at all. You have to have a close examination, and Okay, I tell Dr. Patil, actually, this is not concerned with the ophthalmic examination, but in the first slide, I told you gross examination. Okay, so just looking at the eyes from a distance of 3 to 4 feet, you can change, you can check the changes, rapid changes. The eyes become very furious. If you have seen the normal dog, and even in the case of cattle, their eyes pupil will be dilated, animal will be alert. All these signals are exhibited by the eye. And eye speaks a lot, hundreds of words and regarding the any ailment. And same case in case of rabid animals or in dogs, the eyes become very bright and wide open, and alertness will be shown in the eye. But I never suggest anybody to even go near to the rabid dog for an ophthalmological examination. Okay, Dr. Arun?
For Mukesh, for this, if you want to check the rabid animal to the reflex, you can go for PLR. The direct PLR is almost negative.
No, but that for that also, from gross examination, you can see the PLR from a distance. You can see that the eyes are wide open. Pupil will be dilated.
Yeah. Thank you very much, sir, for feedback.
Welcome, sir.
From the chairman committee.
Any more questions?
Thank you, sir. So,
welcome, Arun.
No more query.
Thank you very much.
I hand over this session to technical committee for further announcement, please.
Thank you very much. Thank you to the organizing committee, Dean sir, Tank sir, Talekar sir, for giving me this opportunity for such a nice session and a good conversation. And I always learn a lot from this kind of presentations and the questions asked by the participants. Thank you very much, sir, for giving this opportunity.
So,
thank you very much.
Thank you, sir. So, the next session will be start by 4 o'clock.
Yeah.
The name surgical management of cataract in dog.
Yeah,
Again, Dr. Jirwal is going to demonstrate all the activity, doing at their place in other field also, in Pandrapur also. So that demonstration will be very fruitful to all the members as well as all the students. So we will meet again at 4 p.m. Thank you, sir.
Okay. Bye.
Bikaner. Sir, I have already delivered the wonderful lecture in the forenoon hour. Now the topic is surgical management of cataract in dog. So, sir, have I think in his biodata he has written that the first veterinary surgeon that in the state that performed the successful cataract surgery by fecal separation method in dogs. So definitely, sir, I have the vast experience in the veterinary surgery and radiology, especially in the cataract. So definitely, our participants have opportunity to gain the knowledge about the surgical management of cataract in dogs. So I give the this screen to Dr. Jirwal, sir. So you can start now your presentation.
Okay, sir. Thank you. Sir, please allow me to share my screen.
Okay.
Okay. Thank you.
Yeah.
So once again, I welcome to all the participants in this second session of this vocational training. And this time we will be discussing about the surgical management of cataract in dogs. And so in the morning session, we discussed regarding the protocol of the ophthalmological diagnosis for various ocular affections. And now in this session, we will particularly talk about the management, diagnosis and management of cataract. Although the demonstration is regarding the surgical management, but I would like to add some slides regarding the diagnostic procedures also, and also a few slides about the basic information that what actually cataract is. So for the beginners or for the newcomers, this will be a introductory lecture in few slides that actually what cataract is, and how it is formed and how it is classified, then how it is diagnosed, and lastly we will discuss regarding the surgical management of cataract in dogs. So as I told you in the morning session regarding various ocular affections diagnosis, and particularly one of the affection is this cataract. And I tell you nowadays, after the pet owners have become aware regarding the cataract surgery at our center, many of them are approaching all over from Rajasthan and even from the neighboring states. So I mean to say that if once you start doing cataract surgery, and people know about your center, your excellence, that yes, you are performing this, we are giving good results, they will approach you. And before that, although the cases were there, but hardly does anybody approach to our clinic for this kind of surgical management of this cataract. So we have to keep doing this surgery for. So initially, just as an introduction, I would like to, I have added these few slides regarding what cataract is actually, how you can define the cataract, and what cataract is all about. So we all know that cataract is unilateral, or more often it is bilateral blindness. Unilateral, it could be many times, many of the causes of cataract are such that it is unilateral. Say for example, when it is traumatic, it is usually unilateral, that the eye traumatized get cataract and other eye is okay. And another is the only effective management of cataract till now known is extraction of this disease lens, and no other medicine, although many research are going on that okay, this can be, the lens can be hydrolyzed and can be resoluted by some drugs, injecting some intracameral drugs. But yet now no effective drug has been launched in the market. So ultimately in human beings and as well as in veterinary also, extraction of cataract is the only treatment for this cataract. And extraction, we will discuss in coming slides that it could be done by 3 techniques that we will discuss. And the success rate is no doubt nowadays, as more and more people are starting doing cataract surgery at their end, the success rate is increasing. And the learning curve, as more you practice, more you learn regarding the cataract surgery, and your expertise and the results become good. So if we talk about the something regarding history of the cataract, then you can say that way back in 5th century, in some Hindu writings, this cataract has been described. And until mid 70s, it was thought that cataract was formed by opaque material flowing. People used to say something has gone. They were not having any idea regarding the lens. They were not having idea what lens is made up of, and why it become white and opaque and all that. They just think that something, a waterfall like white situation is there, and that's why they call it cataract. Then comes in 1747, Deviel performed the first ECC, extracellular cataract extraction of cataract. We will discuss this technique in detail in the coming slides. Then first intracapsular ICC was performed by Sharp in 1757. Then comes this great man, Kellman. He is known as father of phacoemulsification in 1967. So you just imagine that what we are doing in 2021 has started way back in 1967 in its raw form. Although now we have refined a lot the cataract surgery that was conducted by Kellman, and much of rectification has been done in the technique. But yes, we should be thankful to this person, Kellman. In 1967, he performed phacoemulsification. Then with the advancement of the machines and all that, day by day, the incision required for cataract surgery becomes smaller and smaller, and the results become better and better. And modern, as we are talking about the intraocular lens implant that started by Harold Ridley in 1949, when he implanted the first PMMA, polymethyl methacrylate posterior chamber intraocular lens. So nowadays, the method of choice is no doubt even today is phacoemulsification. But I would like to say here that all the centers are not having this setup of phacoemulsification. So yes, you have to be expert in ECC also, extracapsular cataract extraction, and no doubt if the only drawback is a big incision being given of 10 to 12 mm being given in ECC. Otherwise, no problem with the ECC also. You can start ECC. We have also started this in cattle, and at the field level where you are not having phacoemulsification, you can go for cataract surgery by ECC also. But yes, for ECC also you have to learn that how to give incision, a semilunar incision. Then you have to practice the suturing and all the process you have to learn. Then what is cataract? Actually, this was regarding the introduction and history, and now we just talk about what is cataract is, basically how it can be defined. So, it is a group of ocular disorders that is particularly related to lens and its capsule, opacity, particularly opacity of lens and its capsule. And if you talk about that, okay, if there is opacity of cornea, no, it is not called cataract. Cataract is particularly, the word cataract is particularly associated only with the opacity of lens or its capsule, both anterior or posterior. And that also lead to cataract. And yes, it can be of varying size and varying location in the lens. It could be nuclear, it could be peripheral, it could be anterior capsule, it could be posterior capsule. Anywhere it could be the opacity and lead to cataract. And small cataract is usually known as the incipient cataract that does not interfere with the dog's vision. And on the other side, there could be mature cataract where it is complete opaque and there is no vision and the dog becomes temporarily blind. I use the term temporarily because it is a curable disease. You can cause the disease, you can cure the disease, you can remove the lens, and there will be vision in the dog. So it produces cataract, says that it produces gradual, painless, progressive loss of vision. Okay, and the pet owners, they will not no, they will not be aware of their vision loss of their pet, because as I told in the morning that the dog in its familiar environment, familiar place, will not let you know that he has gone blind. But when the owner will notice it when it starts bumping into the walls, and then the owner will know, yes, there is something wrong with the vision of my dog having cataract. Otherwise, there is no pain. So if the pain signals are not exhibited, owner is not going to notice the vision deficiency. Now, as we have seen that cataract is a disease of lens. So what actually lens is? So just a brief about lens, that it is a naturally clear structure located just behind the iris. This is the iris, and it is located just behind the iris and suspended and held by the generally ligaments. These are generally ligaments rising from the ciliary body, and it is avascular, transparent and biconcave structure, and moreover it has a protein concentration of 33% of its total body weight, and most of these proteins are transparent and water soluble. And the basic lens, as you can see here, is having the structure in center. It is having a nucleus and surrounded by the cortex. This is cortical material, and the endothelium of the lens capsule keep on shedding the cortical material onto the lens, and the lens keep on generating. That means this is a region of transformation of epithelial cells into lens fibers. And this is more regarding the lens. It is mostly made up of water and protein fibers, and the transparency of the lens is because of a regularly or in a well patterned arrangement of the lens fibers that makes it a transparent structure. And whenever there is any change in the arrangement of these lens fibers, it becomes opaque. Then loss of temporary opacity formation. Again, I have told you that this is a clear lens, and here you can see the opacity has been there to the lens. Then this is defined as cataract. Okay. Now something regarding the optics, not of that much important, but you should know that how the vision is formed, that light passes refracted. There are different refractive media. Say for it reflects at the cornea, then at aqueous humor, then at lens, then at vitreous, and ultimately it reaches to the retina and the image is formed. And it has been told that whenever this arrangement fails, that is whenever this either this lens, this cornea become opaque, the vision is affected, but that is not the scope of, not in the scope of this lecture. It is not cataract. We are particularly concerned with the opacity of the lens, and whenever there is opacity of the lens, the vision is hampered. That means the light rays are not directly reflected onto the visual focus point. Although it has been told that the dog will exhibit the similar signs as in the human beings, but as it cannot speak in words, so the owner has to notice. So what causes cataract? Just a few things about that, how cataracts are caused. So if we talk about the etiological agents, then you can say that it can be inherited, then it could be because of some trauma to the eye, trauma to the lens. It could be because of some metabolic disturbances like diabetes, hypokalemia. It could be because of toxins. Then nutritional cataract could be there, and secondary to inflammation. And some of the cataract, we do not know the exact cause of cataract. Many times we say, yes, this is cataract, but no exact cause can be ascertained, known as idiopathic cataracts. So I think I should skip these things. Just inherited in certain breeds, this cataract is exhibited more. And again, those who are interested in genetics, they can study it more, that the recessive genes leads to formation of cataract. Then yes, this is something that we being surgeon are also interested in, traumatic cataract. Whenever there is trauma, then this leads to this cataract. This leads to cataract. Why? And many times when if it is a blunt object trauma, then there will be no rupture, no puncture of the anterior capsule, and only will lead to the localized opacification of the lens. And if there is any puncture of the lens, then the lens material may ooze out into the anterior lens, anterior chamber, and it may cause anaphylactic shock, severe anaphylactic shock. As I would like to tell you that the lens protein itself are foreign for our body, and if they are released in the anterior chamber, they move into the blood vessels, blood circulation. They will cause severe anaphylactic shock to the animal, even to the human beings also. And usually those cataracts that are caused by blunt trauma, they are usually this star shaped, stellate, or rosette shaped. They could be rosette shaped. Then metabolic cataract, also known as diabetic cataract, and you have to perform hematobiochemical analysis of each and every dog coming to you for cataract to rule out diabetes as a possible cause. As and generally 75% of the dogs develop cataract and blindness in both eyes within 9 months of being diagnosed with diabetes. And unfortunately, we are getting it as a chronic case. And unless the lens become completely opaque, the owner does not present the dog for treatment. Then toxic materials, there are certain toxic materials like DMSO, dimethyl sulfoxide, and DNP. They also causes cataract. And then comes the nutritional deficiency of many diseases like many vitamins like vitamin D, arginine, taurine, histidine. All these vitamins deficiency, particularly vitamin A deficiency, does also lead to the formation of cataract. Then comes uveitis induced cataract, that it is formed. It is a common complication of uveitis and results from common chronic intraocular inflammation, and corticosteroids used in treating the inflammation. And initially, when you see uveitis, we should tell the owner that if it is not treated well in time, it may lead to formation of cataracts. Then this is regarding the classification of cataract in dogs. This could be congenital at the time of birth. It could be juvenile development at early onset of 2 to 5 years of age. And many times you see you at the age of just when it is seen at the age of what 1 to 2 months, then you can say, okay, it was not, it goes unnoticed by the owner. And when he come to know, he will present the dog and say, okay, there is cataract. So you can classify that as a congenital also, although it was diagnosed a little later. Then capsular cataract. Capsular cataract, as I was telling you, opacity of capsule, not of lens, be it anterior capsule, be it posterior capsule opacity, but the lens is okay, but it is the opacity of the lens. Then subcapsular, just below the capsular, then nuclear cataract. It could be nuclear cataract, only the nucleus of the lens become opaque and the periphery remains to be transparent. And in this condition, there might be a good amount of vision, good quality vision in the dog, although you can see the cataract in the center. Polar, equatorial at the poles of the lens, there could be cataract. Then incipient, earliest lens changes. You can see here the incipient cataract, then immature cataract. Initially it is incipient cataract, then it becomes immature cataract. In how to differentiate between immature and a mature cataract, that in immature cataract, although the vision is hampered, but not completely, the dog does not become completely blind. Whereas in case of mature cataract, as the lens goes towards the maturity, it will become completely opaque, completely white, and no light is going to reach up to the retina, and even you will not be able to look any tapetal reflexes. Here you can see a little tapetal shine in the eye. That means light is coming back from the retina. And so the dog will be having some vision. Then it becomes mature, completely mature. If as it is a very old saying that fundus always says, if I cannot see, you cannot see me. That means if you cannot see the fundus, then fundus cannot see you. So the dog is completely blind. In this case, you can see here that the fundus is not at all visible in case of mature cataract. And as the time goes on and the dog is not treated, ultimately what happen, the mature cataract will turn into the hypermature cataract. And in the hypermature cataract, what will happen? It will start resolving from the peripheries, and many times in case of hypermature cataract, you will see that owner will say, okay, before 2 to 3 months it was completely blind, and nowadays little vision, it has gained little vision. You know, that's why, because there is resorption of the cataractous material from the periphery, and from this periphery a little light is focusing onto the retina, and that is leading to some vision in the. But you should not wait for becoming a cataract to be hypermature, because it leads to many complications. Then different types of cataract in dogs. Different types of cases of cataract of dogs. You can see here clinical cases of immature cataract, different immature eyes. You can see cataractous eyes. Then different cases of cataract of mature cataract. You can see different cases of mature cataract. Then this is a case of hypermature cataract. As I was telling you, the periphery resorption of the peripheral cataractous lens is there, and you can see some greenish tapetal reflexes are from here. So, and then again you can see a hypermature cataract with glaucoma. As I was telling you that in cases, if you do not treat it timely, then hypermature cataract will turn into mature cataract. But during that period, it may cause many complications like uveitis, like glaucoma, and other haziness of the cornea, and synetia, anterior synetia, posterior synetia, and many more complications could be there. So better handle it at the earliest, better handle it at the when it starts maturing. You start maturing, you can perform the cataract surgery. Then how the cataracts are diagnosed. In the morning also, I saw this slide and tell, yes, particularly in case of cataract, you have to look for the complete examination of the cornea, then lens, and the adnexa also. And particularly importance is of corneal clarity. If the cornea is not clear, you cannot go for phacoemulsification. And even if you perform ECC, even then if the cornea is completely hazy and completely opaque, then no result of performing a surgery in even by ECC, even if you remove the lens, cornea is opaque, so there the prognosis is very poor. So you can see here the cataractous eye showing focal corneal opacity, then a complete haziness of the cornea with scleral vascularization. And here in such cases, these are the best cases to be treated. As you can see that the cornea is completely clear and you can see the white cataractous lens. There is no vascularization of the sclera, limbus, you can see here. So it is a beautiful case for operating as a phacoemulsification. Then you can search for conjunctival vascularity, although this is not of much importance, but actually what causes problem is that although cornea might be clear, but if there is vascularization of the surrounding sclera and conjunctiva, then ultimately what will happen after performing phacoemulsification or ECC, what will happen? These blood vessels will appear as ghost vessels and will traverse onto the cornea and spoil your surgery. So always look for the clarity of the conjunctiva. Then ocular discharge, yes, if there is any kind of infection, if you suspect some kind of ocular infection in the eye, then always check that infection before moving on for the cataract surgery. You should check the infection, you should sanitize the eye, you use antibiotic, anti-inflammatory drugs, and then start the surgery. And then again, I'm not going to describe these all as we have discussed in the morning, that you have to perform all these. This is a protocol for cataract surgery. You should follow all these protocols. You should conduct all these tests. Although these basic tests are much more important, and even if you do not perform this ultrasonography or ERG, then if you are not having facility, then also it is okay. No harm, much of harm is going to be after surgery. But yes, you have to evaluate the visual status of the dog, cataractous dog, before proceeding for the cataract surgery, because it might be a case that if the retina is completely gone, then even if you conduct a successful surgery, cataract surgery, even then the dog might not be able to see. So again, I think I will not discuss. I will skip this, because in the previous slide we have seen this is Meniere's reflex test in cataract. You can see this cataract eye showing no response. Again, corneal reflex test, as we have discussed. Then PLR, pupillary light reflex test. You can see here how the wide open iris is fully dilated, and you can see the complete lens. Although here you can see the cataractous lens, but it is surrounded by the iris. There is constriction of the pupil in these cases. And such cases, I prefer to go for cataract surgeries in these cases where PLR is okay and cornea is clear, okay, and having a good PLR, they will give a good result after phacoemulsification. Then this is regarding PLR again, that while performing cataract surgery, you will find three kinds of patients. And this I think I didn't discuss in the morning session, that blind patient with normal PLR, okay, these are blind, having normal PLR, even then they are blind. That means there is some kind of cortical blindness is there. You cannot, do not have much of the scope. Blind patients with abnormal PLR, yes, both, it can be said that both retina and retina is completely gone. That means it is blind and having abnormal PLR. And these are visual patients with abnormal PLR. So these are some patients, as I told in the morning, that they might be having some neurological disorders. again, obstacle course test. I am not going to simultaneous test you have to perform. So you have to perform all these cases before non-contact tonometry. We have discussed in the morning. USG we have discussed in the morning with detail, and ophthalmic examinations. Yes, we have discussed retinal examinations. So all these protocols we have discussed in the morning, so need not to discuss here. In the morning, I was not having this slide, so you can see here the position of the electrodes. The main electrode, active electrode, has been placed over the cornea. This is the reference electrode, and this is the ground electrode. How they are placed and how it is the dog is positioned, and the normal electroretinograms are received. And this is a case of SARD diagnosed by us, sudden acquired retinal degeneration. And this dog was having no, you can see here, no waves, no rod and cones responses were there, and straight lines. And I always used to say, whenever there are straight lines of retina for retina responses, you can say retina is gone and now there is no more scope. Hematobiological, as I have told previously, that to rule out certain systemic diseases, you have to conduct this hematological examinations. Now, after having a ophthalmological protocol for cataract cases, you will find many of these cases immature cataract. You can see here, this is mature cataract. How beautiful mature cataract is this, and it looks that yes, okay, you just put the probe in of the phaco and just extract it out, and the vision will be okay. And here you can see a hyper mature cataract. The total fragmentation, you can see here how it look as the sparkling firecracker work of the inside the eye. How beautiful it, if you zoom it out, it looks very beautiful. And it is because that there is complete fragmentation of the lens, and when you shine a bright light onto the eye, the light scatters, and this is scattering of light in beautiful manner. Here again you can see a mature cataract with lens luxation, that I was talking about the crescent. It is, you can see here that it has a lateral lens luxation, and in here you can see the posterior synetia. That means there is adhesion between the lens and the iris. You can see the inner portion of the iris and the lens, they are adhered, and this was a case of traumatic cataract. Now come on to the main topic of surgical management of cataract. So as I told you that particularly there are three techniques by which you can treat the cataract. You can perform the cataract surgery. Number one is ICC, also known as intracapsular extraction of lens. Then it comes ECC, extracapsular cataract extraction. Then it is phacoemulsification, or with or without IOL implantation if you are having intraocular lens, and if the capsular bag is okay and generally ligaments are healthier and they allow you, they have the holding capacity, you can implant the intraocular lens. Otherwise you can leave the eye aphakic and there will be pseudophakic vision also. So we will discuss these techniques one by one. Actually, before moving on to the next slide, I would like to tell that ICC, intracapsular cataract extraction of lens, I have not included in my discussion as this technique has become obsolete. But even though this has become obsolete, this is rarely required. It is required in cases where the lens is completely separated from the general ligaments, and the general ligaments are not healthier, and there is complete lysis of general ligaments, and in that case you cannot perform the capsulotomy, and you cannot perform the capsulotomy, so you have to completely as the lens will be suspended in the vitreous. So you have to completely remove the lens along with its anterior and posterior lens capsules. So it is rarely used. So we will discuss in detail regarding the ECC and phacoemulsification. And phacoemulsification is, you can say, a type of advanced extracapsular cataract extraction. Up to some extent, the procedure is more or less same. That I will show you from where it bifurcates. It becomes a phacosurgery, and up to where it is a common of ECC and phacoemulsification are having common procedures. So we begin after diagnosis. We take the animal dog onto the table and position under the operating microscope. This is operating microscope, and we put the animal under this operating microscope, and position of the eye under operating microscope. And after putting it, you have to sanitize the eye by using povidone iodine. I will show in the coming slides. And this is retrobulbar nerve block anesthesia. If we talk about the anesthesia, okay, it is always performed in under GA. General anesthesia should be given, and besides GA, we have to use this retrobulbar nerve block also. This gives us, this facilitates us retrobulbar nerve block in two ways. One is it fixes the eyeball, there will be no eyeball movement, and second, it bulges the eye as we are depositing the 2% lignocaine hydrochloride behind the eyeball. So it will lift it up. When many times you will see that the dogs are presented with the sunken eyes, then the eye is bulged out. And if it is bulged out like this, it becomes very easy for the surgeon to go for surgery. Then a adjustable, self-adjusted wire speculum can be placed onto the eye. And these are ocular drapes, plastic drapes. You have to create a window from this, and then before starting the surgery, you have to paint this with betadine, povidone iodine. Okay, you have to save it properly, save the site and paint it as required for the surgery. Then the first incision is given on cornea with keratotome. I think if you can see my video. Am I visible to all the participants? Hello?
No, sir.
Sir, if I show you some instrument, can you look at these instruments?
Yes, yes.
Can you see this instrument?
Yes. Yes.
Is this visible?
No, you are supposed to adjust your video.
Adjust my video.
Yes.
This is my camera. So can you see this instrument?
Yes, yes. Now
you can see this instrument.
Yeah.
Okay. So actually, I just want to tell that this is the keratotome. This one is 15-degree lens set, and this one is keratotome. I just want to show the students some instruments. This is the keratotome. I think it is just in front of the camera, and it might be visible. You can see it has been bent at 45-degree angle, and it is having 3 cutting sides. I think the video is not that much okay, but if you can see, then you can see here this is having 3 cutting sides. From front it is very pointed, and from the 2 sides also it is pointed. So this is used to create the main port in case of ECC as well as in case of phaco. So we are this keratotome is of different size, and it is a keratotome of 2.8 mm. This gives a incision of 2.8 mm, and another keratotome that you will find in the market is of 3.2 mm keratotome. And initially you start with 3.2, but as you expertise, you will you can perform the surgery by 2.8 mm of man port. By 2.8 mm, even you can perform phacoemulsification, and initially in case of ECC also 2.8 mm incision is given to create a man port. And now up to here, phaco and both procedure are same. Then standing of anterior lens capsule by trypan blue. We are having a trypan blue dye. Just inject about 0.5 to 1 ml of trypan blue dye. I think yes, all of you are aware regarding the trypan blue dye. Then after injecting, just keep it for about 1 minute, and then flush it out with BSS, buffer saline solution, or Ringer's lactate. Then you can flush it out. Then what will happen? This dye will be painting standing over to the anterior lens capsule. Otherwise, what we have seen that in previous slides, that the capsule becomes sees white because the lens has become white. Lens has become opaque, and the capsule will also become white. So when you will start performing capsulotomy, it will not be differentiated whether you are giving incision over to the lens, or you have just done the capsulotomy, removing a piece of capsule. So after taking this stain, it becomes very easy, as when you remove a circular piece of anterior lens capsule, the white lens will appear from below. Then you can see here how the anterior lens capsulotomy has been performed. You can see here a piece of anterior lens capsule has been removed, and after removing, the white cataractous lens is quite visible in the capsular bag. Then up to here, I would like to tell you that up to point number 9, removal of broken anterior lens capsule. This is known as capsulorhexis, capsulotomy. After performing capsulorhexis, giving an incision, this is known as capsulotomy. So you have performed capsulotomy. So up to capsulotomy, phacoemulsification and ECC are having similar procedures. But after, from here, with the path is diverted. That for phacoemulsification, you have to put the probe from this 2.8 mm incision and extract the lens from the capsular bag. And in case of ECC, you have to increase the incision. Here you see that we are enlarging the incision of 2.8 mm to about 10 to 12 mm. And even if we say that it is a circular limbus of 360 degree, even a 180 degree, up to 180 degree lens, incision, limbal incision can be given. Now, this is a method of, you can say this is a method of practice, that you either you give incision at limbus or sclera. The two ways are there. Either you give the incision at limbus or clear corneal incision. This is in my picture, you can see my photo, you can see here that this is a clear corneal incision, and even you can give the incision at limbus also. So a clear corneal incision sufficient to remove the complete intact cataractous lens is to be given. Now here you can see that after giving a incision, this complete cataractous lens, as this lens was hypermature, so it will break up. And in case of mature cataract, you will get this kind of intact lens. You can see here in this picture that this kind of intact lens is extracted out. You can use this spatula. We use this spatula, a kind of instrument is there that you just scoop it out. The scooping action from the first you have to separate the lens from the posterior lens capsule by hydrorepulsion. Then you have to scoop it out. You should not damage the posterior lens capsule, or you should not put undue force, as it is always said that while performing ophthalmoscopy, you should use only the pressure up to your wrist and your fingers. No pressure beyond your wrist should be put onto the eye during ophthalmic surgery. No need of using this arm. You use only these hands, only wrist and fingers. You have to work with fingers, and movement of only wrist movement is there. So in this case, don't put undue pressure and just separate the lens from the posterior lens capsule and extract it out. And the remaining material, if any left over there, you can see, you can remove it with the help of these forceps, and easily it can be removed if there is any piece left over there. So this was something regarding extracapsular cataract extraction. And after removing the lens, you have to suture back the cornea. Now, for suturing also, as this is a simple PPT, and had it been a live training, I would have told the students that suturing is also a very essential or important part in case of ECC, for successful case of ECC. And if in suturing, all these procedures are done under operating microscope, and if you are trying to perform it by naked eye or some high power lenses, then you know you will suture the lens, suture the cornea along with the endothelium. And I always prefer that the endothelial layer should not be pierced, and the cornea should not be punctured fully, and the layer should be sutured. And the corneal suturing can be done with the help of 8-0, and if you are expert enough, you can use more fine thread of a 10-0 absorbable suture material you can use. And the most important thing is that the knot should be kept towards sclera, not towards the cornea. You should not keep it toward the cornea. Always try to keep the knots away from the cornea, so that in post-operative care, they do not disturb, they do not rub over to the cornea by the eyelid forces and causes corneal opacity. And here you can see that the white lens has been removed, and you can see through this pupil, you can see at the fundus. And immediately, I tell you, immediately just after removing the lens, you will notice that dog has gained the vision. Then immediate post-operative view, you can see here, then tarsorrhaphy should be done. This type of lens, recovered cataractous lens, you can see. Again here, if you look at this lens, you will see that this is the nucleus, more opaque, and a less opaque cortex is there. And this type of bandage can be put over to the dog's eye. So this was, I think this is all about extracapsular extraction of lens. So sir, Talekar sir, hello. Hello.
Yes, sir.
Sir, I would like to I would like to just interact with the participant that before moving on to the phacoemulsification method, if they have any question regarding this, they can ask, because it is a type of demonstration and I don't want to make it hectic that I finish all the things and they will forget to ask the. So if you permit me, I can give a break for question answer session here for this ECC. If they have any confusion regarding ECC, they can ask.
Just a minute. Our rapporteur, asked some question regarding ECS.
Yeah. Welcome.
Hello, sir. Hello, sir.
Yes.
Sir, first of all, sorry, I am not surgeon. I am basically genetic trader, so my question will be somewhat.
Excuse me, madam. Excuse me. Please wait. Let me put on these earphones, as your voice is not clearly audible to me. Actually, I was told that this is a demonstration session, so better we should make it a discussion, not just presenting the PPT, and so let's discuss regarding cataract. Let me use this earphone. Hello.
Hello?
Hello. Yes, yes. Now speak, ma'am, please.
Okay. So what about the fluid present in anterior chamber? It is to be deposited when we are removing the lens after that.
Ma'am, your voice is not clearly audible. It's
Hello, doctor.
सर आवाज बहुत गूंज रही है आपकी.
Wait, sir.
आवाज बहुत ज्यादा इको, there is echo sound.
Just a minute. Now
Hello?
voice is clear.
Your voice is clear, but when ma'am was speaking, there was some echo sound and disturbance in the sound.
Madam, what?
I don't know what actually the problem is with system, my system or something else. Yes, ma'am, please.
Hello, doctor.
Yes, yes.
In extracapsular cataractic surgery,
yes,
if you open the anterior chamber, what kind of fluid you want to ask?
What type of fluid? Yes, good question. Actually, as you asked the question, I realized that I missed that point. You have to maintain the. You are asking about the irrigation fluid, na? Irrigation fluid, na, sir?
Vitreous fluid which is already present in anterior chamber. It is to be
Irrigation fluid.
Yes, yes. I don't know.
Yes, normally we are using Ringer's lactate. Otherwise, buffered saline solution is also available in the market. You can use that for irrigating the eye, for the capsular bag, clearing the anterior chamber. But at our place, we are usually using this Ringer's lactate, RL.
Yes, she want to ask about Viscomat jelly, sir.
No. Actually, I tell you, yes, I was going up to her question. Ma'am, Viscomat is not of much use in ECC. You see that when we are just creating a side port, main port, and we inject the trypan blue, okay? After injecting the trypan blue, the anterior chamber, shape of the anterior chamber is maintained, okay, by the fluid. Then Viscomat is particularly more of use in case of phaco, where we are performing the surgery by just 2.8 mm of incision. Here we are opening the cornea. You see that in the previous slide I saw you that we have opened the cornea. We are incising it, we are enlarging it, so the anterior chamber will collapse. When you are giving a big incision of 10 to 12 mm or up to 180 degree, the anterior chamber or complete aqueous will be out for some time temporarily, okay? Again it will be secreted as soon as you close the eye, and ultimately before I'm telling you, before putting on the final suture for ECC, even if you just put one bubble of air, that will maintain the anterior chamber, and by the time in the coming time the aqueous humor will be secreted back, and the position normal shape of the eye will be maintained. So this Viscomat is not of much use in ECC. Only while doing capsulotomy, if you are having some problem, you are facing some problem, you can use at that time. Otherwise, after that, no need of Viscomat in ECC. Particularly in ECC, it is not being used. अरे दरवाजा बंद करना कपिल. दरवाजा बंद कर दे यार. हाँ, yes. Any more questions? So, should we proceed for phacoemulsification?
Good afternoon, sir.
Yes.
Hello.
Yes. I'm listening you.
Yes.
Sir, how much ml lignocaine is used for retrobulbar nerve block?
How much lignocaine? Yes, lignocaine actually we are using in a diluted form. Our aim is we are just using, you can say, about 2 to 3 ml of lignocaine, 2% lignocaine hydrochloride that is mixed with normal saline. We mix it normal saline and we inject it at the retrobulbar space, and that will work. And if we need further fluid to bring the eye up, then usually we do not inject much of lignocaine than 2 to 3 ml. Then we inject the fluid, simple fluid. Lignocaine 2 to 3 ml is sufficient for fixing the eye. Because if you are giving more of this lignocaine hydrochloride, I have seen that it will lead to chemosis. It will lead to chemosis, that is swelling of the bulbar conjunctiva. That will cause problem with your surgery. That's why we are not using it in large amount, and only 2 to 3 ml is sufficient for fixing the eyeball. And in ECC, particularly in ECC, even if there is a little movement of the eyeball, although there is no movement, but even if you fall short of this anesthesia and the eyeball is not completely fixed, ECC can be performed easily. No problem with the ECC.
Okay, sir. Thank you.
Welcome. So I think no more questions regarding ECC. So we should move on to phacoemulsification technique.
Yes, sir. You go further.
Okay. So regarding phacoemulsification, as I have told you that the learning curve of this is, it takes a much more time and need lots of practice to expertise phaco. Actually, if we are performing in, experimental animals, then it's okay. And actually, wet lab practice should be done. At least you can use buck head or buck eyes, or you can get the eyes from buffalo, calf eyes from the slaughterhouse, and you have to practice the phacoemulsification procedures before moving on to the clinical cases. And the machine, you have to be familiar with the machine. Different kinds of machines are being used at different centers, as the one being used at Junagadh is quite different from that we are using at Bikaner. So you have to be familiar with machines. At least you have to know how these machines work. And regarding instrumentation, if we talk about instrumentation, then you can see that this operating microscope is used both in ECC and as well as in phacoemulsification. And this is the phaco machine that we are using here. Apasami phaco machine is there. We are using it at our center. These are some other accessories of phacoemulsification. This is the main handpiece. You can see at one end it is having the place for putting on to this needle, phaco needle, and this end is put on to the phaco machine. What this Hitesh Katara is doing, lots of arrows. Then, this is irrigation aspiration assembly. This is also used during phacoemulsification. We will see in the coming slides. Then this is the chamber, testing chamber, used for testing the proper functioning of phacoemulsification. And what we are doing, this phaco needle is just put on over this handpiece at this place, and this over this needle, this is the needle sleeve. This is known as needle sleeve. This is having two opening just few beyond its anterior most part, and these are for irrigation. The water or fluid, rather fluid is irrigated during the phacoemulsification, while this needle uses ultrasonic power to cut, and these two holes are used for irrigation, and this is the wrench used to tighten the needle over the phaco handpiece. So this is the assembly and of phacoemulsification. Then this is a routine surgical instruments, routine ophthalmic surgery instrument that we are using here. You can see this is the corneal forceps, and these are various types of capsulorhexis forceps. They actually, this capsulorhexis forceps and these are time forceps. They look very much similar, but the only difference is that these capsulorhexis forceps are having tooth bended, the end of are bended, and it is having tooth at the end point, and these are simple plain, they are no tooth, and they are used for tying, you know, in when you are suturing, they are known as tying forceps, because when we are suturing many a times, although this you can see here, this is the needle holder, here you can see the needle holder, this is the scissor, but many a times even the needle holder, there is no space to suture the needle holder, use the needle holder, then these tying forceps are used, and you know, very gently the knots are being tied, otherwise other these instruments, the needle and scalpel, BP handle, and these are two instruments that, as I have shown you, one is this keratotome, and another one is this 15-degree lancet. This is known as 15-degree lancet. If you can see this from this video, from this camera, this is known as 15-degree lancet. This is used to create a side port. The main port is created by this keratotome. You can see here this keratotome 2.8 to 3 mm, 2 mm, and this is the side port, and you have to just puncture the cornea by this side port. Then some of the instrument you can see here, utrata forceps, capsulorhexis forceps, known as capsulorhexis forceps. Then Sinski's hooks, straight and bent. These are also known as a nucleus rotator. They are used during surgery to rotate the lens while performing this cataract surgery by phacoemulsification. Again, this is nucleus rotator. You can see here. Then these are irrigating cannulas. This type of irrigating cannulas, they are readily available in the market at the human ophthalmology shop. You can procure them of different size, and one we are using it. This is of 22 gauge. Another is 20 up to 27 gauge. If cannula can be used, these are irrigating cannula. Whenever you are putting viscomat or any other fluid, or you can say that dye, they are injected by these cannulas. No sharp needle are used in phacoemulsification or in ophthalmic surgery. Then you can see here this cystotome needle. This is bent from anterior end, and they are used to create a incision over to the capsule, and that's why they are known as capsulotomy or cystotome needle. And this is the keratotome that I was trying to show you from my camera, but I think here you can easily see this having 3 cutting ends at anteriorly and on the both sides. This is having cutting ends. Then this is the lens, injector, and cartridge. You can see this is the intraocular lens implant assembly. The lens is 41 diopter lens available in this type of sterilized packet, and you have to open it up, flip open this lens like this, and you have to load this lens. If as I can see that this is the lens, optics and haptics I can see. Hope you it also be visible to you also. So you just pick it up and load it over to the cartridge, load this cartridge over to the injector, and inject in the capsular bag that we will see in the coming slides. Then a little bit about IOL, what intraocular lens looks like. Those who have not seen, I would like to tell that this is the optics of the lens, that is the part that is responsible for refraction of the light vision from here, and these are known as haptics. You can see here this is, and these are also haptics and these are also haptic. These two different types of lenses are there. They are used as either as rigid or flexible intraocular lenses. And as I have told you that what optics and haptics are there. Then what material they are made up of. You can see that optic material is usually made up of non-foldable rigid intraocular lens. If we are using non-foldable, that means rigid intraocular lenses, then it is polymethyl methacrylate. And if it is foldable, then it will be silicone, hydrophobic acrylic, and this is hydrophilic acrylic could be there. And I tell you that the price, morning Sir Talekar sir was asking about the price. So the price of these lenses increases with these qualities. Either it is hydrophobic or hydrophilic. And if it, the haptic material, regarding haptic material, again, it is made up of PVV, PMMA, and it need not to be much of flexibility. Otherwise, it is also made up of polypropylene and other materials also. These are some of the drugs and other injectables that are used during phacoemulsification. And this type of, I just want to show you that this type of eye dresses, this is known as eye dress, are available for human use, and we are also using this for canines. So they just post-operatively, they just protect the eye while you are bandaging. No undue pressure will be put on to the eyes. They will save the pressure over the eye. Then the important thing regarding phacoemulsification is the selection of patient. I always say that the dog you are operating should be such that in the post-operative care it should cooperate. If you see that owner is saying that okay, it will not allow me to put the drops and it will not take any injectable, it will not take any medicine, then better you avoid the surgery. Otherwise, that surgery will give you a very bad name, because although you have performed a better surgery, but if the follow-up is not proper, that will spoil your surgery and give you a very bad name. So any excitable or fractious dog that cannot be handled and medicated is usually an unsuitable candidate. I always prefer that I will tell the owner that okay, your dog is not fit for this phaco surgery, I cannot operate it. And if I operate, I take it written that you should follow all the instructions, otherwise I will not operate it. Then middle-aged patients, immature cataract, these are the ideal surgical candidates. And the dogs should not have any other ocular or systemic abnormalities. Otherwise, as I told you, a dog having ocular discharge, and if you operate, that is already having infection, that will spoil your surgery. So better rule out this kind of infections before moving on to the phacoemulsification or any cataract surgery. Then preoperative procedure. What preoperative procedure we are following is that we advise the owner that you have to instill the eye drops, antibiotic and anti-inflammatory eye drops for 7 days, and then tropicamide 1% should be used as mediatic agent. And before surgery, 1 day before surgery, we start instilling tropicamide 1%, and on the day of surgery we instill it at every 15 minutes, then 10 minutes, and ultimately when we are just approaching for the surgery, we tell him to instill the drops at 5-minute interval. Then 5%, 0.5% povidone iodine drops should be instilled on the cornea prior to surgery for corneal sterilization. Then anesthesia, as I have told you, need not to discuss much regarding the anesthesia. General anesthesia, surgery performed under general anesthesia and retrobulbar nerve block, depositing 3 ml of 2% lignocaine hydrochloride behind the globe at orbital structure. So 2 to 3 ml, as it was being asked in the previous session, previous lecture. Then phacoemulsification, the surgical sequence, what steps are to be taken for phacoemulsification. First of all, corneal tunnel entering into the anterior chamber should be made. Then CCC, continuous curvilinear capsular axis, is performed. Hydrodissection is performed. Then phacoemulsification, aspiration of cortical lens matter, and intraocular lens insert. So these are 6 steps. You can say you can divide the complete phacoemulsification procedure in these 6 steps, and all the steps are equally important up to intraocular lens insertion. This is a matter of choice, either you are inserting intraocular lens or not, but up to number 5, aspiration of cortical lens material, you cannot skip any procedure, any sequence. So you have to follow this sequence. Now, this is a pictorial presentation of the operative procedure. In the coming slides, complete pictures will be there. If anybody asks to ask any question regarding these slides, he can ask in between also. You can interrupt me in between. I would be very happy to be interrupted. So these are the pictorial presentation of operative procedure. As I told you, retrobulbar injection of 2% diltiazem hydrochloride. Then just painting of the surrounding surgical site with povidone iodine, you will see here. Then putting a drap over the eye, making the window in the drap. Then after creating a window, application of speculum, and the final positioning under operating microscope. And this positioning is something very important. It cannot be described in one sentence. Positioning is, you should be very much comfortable while performing this phacoemulsification. As I told you, that only the movement of your wrist and finger should be there. No movement beyond this wrist, or no pressure from beyond this wrist should be used during phacoemulsification. So a surgeon should feel comfortable. So a comfortable position should be occupied before starting the cataract surgery, and the operating microscope, once fixed, should not be moved in between the procedure. Once you have fixed it, okay, you fix it and you get your position, and then start the surgery. And usually the dog is taken in lateral position, and the head is slightly elevated. It's slightly elevated head, so that it can be easily, the eye can be easily approached. Then I tell you that the entry point, or creating a canal into the cornea. And again, this phacoemulsification can be performed by 2 ways. By 2 routes. One through the clear corneal incision. Here you can see the clear corneal incision. Another one is limbal incision, and third one is scleral incision. That is also being minimal scleral incision in human beings also they are using. So in our case, actually the difference of anatomical position is such and such that in human beings, the sclera is when the animal is put onto the table, you will see that even in our eye, you will see that a more of sclera is visible to you by your naked eye. In case of dogs, the eyeball is positioned such that more of the cornea occupied the ocular space, and a very less scleral site is seen. So that why for creating scleral incision, you get very less space. So better we go for a clear corneal incision, that is more easy, and even that there are less chances of this iris damage or puncture of iris. So you can use this. So as this says that entry into the anterior chamber, a scleral tunnel incision or clear corneal incision. So this is clear corneal incision, or uniplanar or stab incision through the cornea, or giving a step-by-step incision. It is known as a step-by incision. The the cornea is having a thickness of just, you can say, 0.5 mm to 0.7 mm. In that thickness, you have to give the incision in a stepwise, so that it becomes self-sealing. It becomes self-sealing, that Even after you remove the keratotome, there will be no drainage of the aqueous. It becomes self-sealing. So a step shape it is called a step shape incision. So a 2.8 or 3.2 mm incision can be given. Then here you can see a clear corneal incision with 2.8 mm keratotome is being given over here. And after this, anterior capsule staining with trypan blue has been injected, and then it will stain the anterior lens capsule. Up to here you see that the procedure is same in case of ECC and phacoemulsification. Then flushing of trypan blue with hydro, and then we inject viscomat. Ma'am was asking regarding this viscomat. So this is of more importance in case of phacoemulsification procedure. In ECC, what we were doing, just after flushing out the trypan blue, we started increasing the incision, so that will collapse the anterior chamber. The incision is very big, so you need not to maintain the size, as you are not disturbing the endothelial layer of the cornea, because you have already made a big incision. But in this case, in case of phacoemulsification, the incision is just 2.8 mm. So when the incision is 2.8 mm and you are using phaco probe, so the injury can be by water turbulence from the phaco, or by the needle, phaco needle. If it touch to the endothelium, that will damage. So that's why we always keep the position of the anterior chamber in its normal position by injecting this viscomat. Then entering the anterior chamber, adrenaline diluted in balanced salt solution injected intracamerally, and the BSS maintain anterior chamber. Adrenaline is used to prevent any, if there is any slight bleeding is there, if it touches to the iris, that will also be checked. And other advantage of this, it will keep the pupil in dilated stage. Then this kind of viscoelastics are being used. It behave as a fluid during injection and removal, and static state acts as a semi-solid within the event. Once it is injected, it becomes semi-solid type, and the usually in routine this sodium hyaluronate, then chondroitin sulfate and hydroxypropyl methyl cellulose viscoelastic materials are being used. This type of, they are pre-filled injections. This is known as viscomat PF. Pre-filled injections are available in the market, so they are used during phacoemulsification. Then we create the continuous curvilinear capsular axis without increasing the incision. You see here that a capsule piece of circular piece of lens capsule, anterior lens capsule has been removed, and you can see the white portion in between the surrounding anterior chamber and anterior capsule. You can see the lens, white lens, from where the lens capsule has been removed. And this is in this picture you can see how the capsule is capsular axis is being formed. This is pictorial presentation, and how the incision is made. Then regarding why the capsular axis is formed, advantages of capsular axis we have already discussed, and need not to discuss much, but the care should be taken that the tear should be in a circular fashion. It is known as continuous curvilinear incision. A circular incision should be there, and a radial tear, you know, if it occurs, a radial tear, then you know it will move up to the periphery of the anterior lens capsule, and that will damage your surgery. The capsular bag will not be created, and it may tear off from the peripheries. So it is better always create a circular incision, and no loose jagged flaps of anterior capsule should be left. Then after creating, after performing capsular axis, we just create the side port with 15-degree lancet, as I show you in the picture that a 15-degree lancet is used to create. So this is in case of bimanual phacoemulsification. Again, I would like to tell that many surgeons are using single-handed phacoemulsification. They just create one side port, and they will not create this. They will not create this side port. They will just create this main port and insert the phacoemulsification probe, phaco probe from this, and extract out the lens. But yes, if you can practice bimanual, will help you a lot in getting more of success in case of phacoemulsification. Then after creating this side port is used to insert another instrument, as I show you, the nucleus rotator, that helps you in creating the initial deep trench. So as first deep trench is created here, from here to here, then I should rotate the lens, and again a plus sign will be created. Then the second trench will be from here to here. So a plus sign is created in the lens. Here you can see initial deep trench is being made into the lens capsule. This is the pictorial presentation how the deep trench are made. You can see here that the first trench from here to here, then you rotate the nucleus. You can see this is the nucleus rotator, and again a plus sign is being created here. And then the engulfing of the capsular pieces starts by phacoemulsification, phaco probe. Here you can see sculpting is going on, and phacofragmentation, the phaco lens, the lens, cataractous lens is being broken into 4 pieces. Here you can see it is being broken into 4 pieces. Again, you can see here phacofragmentation is going on, and you can see it has been broken into small pieces, 4 or 6 or more pieces, and then one by one that piece is eaten up by the fragmentation, phacofragmentation and aspiration. Both this technique is being used, and in between these phacofragmentation and aspiration, again you have to use this viscomat continuously, because you have to maintain the anterior chamber. Otherwise what will happen, that if the endothelium will touch to the phaco probe or phaco needle, then the endothelium will be damaged and the cornea will become opaque. The endothelium will become opaque. Here you can see how this aspiration and irrigation tip is engulfing the cortical material from here. Again, after you see that most of the nucleus has been eaten up by the phaco probe, then the final cortical cleanup should be carried out. You should look for any piece of cortical lens material remain in the anterior capsular bag or into the anterior chamber. Then you have to also aspirate out that. Here you can see the final cortical cleanup is being going up, and then with irrigation, then here you use this irrigation aspiration, because if there are minute pieces left over there, they need not to use the phaco power, as the phaco dissection is not needed at this point, and they will be aspirated by this irrigation aspiration unit easily, and you can flush it out through this main port also. And immediate post-operative view of the eye, you can see here no tissue, no lens material has been left over, and a clear pupil you can see here. And the beauty of this is that there is no incision except this 2.8 mm incision and this 15-degree lancet incision, a minute incision, and these both incisions are self-sealing. So you can say this is a sutureless technique. Phacoemulsification is a sutureless technique, and in case of this 2.8 mm, you can go for stromal sealing. You just inject some fluid into the stroma that will seal itself. Now, how to implant the intraocular lens? I have shown you the lens material. You can see here how the lens is being loaded over to the cartridge. This is cartridge. You just put this, hold this lens with the help of this forceps and load it over to the cartridge. And I always advise that a drop of viscomat should be put into this cartridge before this viscomat drop is being put into this. You can see here, and you can fold the lens and insert into this groove. You have to insert this groove, and then you have to lock this cartridge. This cartridge is locked, and this should be loaded over to the injector. This is positioning of the this is, you just see here that how this is loaded over to the injector, and after loading over, this should be injected into the capsular bag. Okay, now as soon as you insert this intraocular lens into the capsular bag, this will unfold. But again, you have to position the lens haptics into the capsular bag. So we use this nucleus rotator instruments without any notch, and you can place the intraocular lens into the capsular bag. Here you can see the immediate post-operative view of the lens being placed into the capsular bag. And finally, what we do, just inject some drops of air bubbles. These will be absorbed, and the anterior lens capsule, capsule is will be maintained in the coming time. So this is immediate post-operative view. And here is a short video clip. I think it will work. A complete phacoemulsification process has been shown here. So just 1 minute clip, please see this if it is working. Why it is not working? PowerPoint was unable to locate the linked media. Oh my God. I don't know why it is not working. So sorry, I think this video is not working. Okay, this video was showing some complete phaco procedure, and let me try at last if it works.
Hello.
Yes, sir.
Doctor, you can play separately.
Yeah, let me try if I can play it.
And don't use this PPT.
Okay.
Source.
Then it will be visible to you?
Yeah, definitely.
Okay. Let me see. Sir, is it visible to you? Hello?
No, sir.
Is this video visible to all of you?
You open first on your desktop and then share it.
Okay, okay.
Minimize the PPT.
Okay, okay. Let me see. I think now it will be visible to all of you.
Okay.
Hello?
Yes, please. Okay, slide 114.
Yes. This is a video that I want to show. Is it visible?
Yes, sir.
Okay. So you can see here, this is a short video showing the complete FACO procedure that we are adopting here. You can see that we are putting the eye drap over to the and this was what I was telling you, just to lift some head. We have put some cotton below the head, and you can see that this drap is being placed over to the eye. And here we are creating the window into the drap. And you see that this is the main incision, main port has been created with 2.8 mm, and this is side port. This we are creating side port. You can see second port. This is the expertise that you have to get. And this again, we are injecting this trypan blue, flushing out the trypan blue. You can see here, flushing out the trypan blue, taking it and on. And you see here that visco gel is being injected, and this is capsulotomy being done. Capsulorhexis is being done. You can see we are just giving incision, and this is, you can see how phacoemulsification, creating trench. Phaco in progress. You can see that the final short piece of lens, how the probe is eating up the lens material. And this is the second port. From second port we are using this nucleus rotator. You see the complete lens has been, you can see here a clear lens, clear pupil. Most of the lens material has been irrigation aspiration in it, and this is how the lens is being loaded over to the cartridge. Loading of lens over to the cartridge, locking of the cartridge, and locking of the cartridge, and now it will be loaded over to the injector. You see here, this is being loaded over to the injector. You see that this has been loaded over, and this is how it is implanted into the intraocular, is in the capsular bag. And again viscoelastic material, and this is final injection of dexamethasone and gentamicin, and final tarsorrhaphy being done. You can see here. And we remove this tarsorrhaphy suture on the very next day. We put it only for 1 day, and very next day we will examine and remove this tarsorrhaphy suture. So this was a short video, and here you can see the application of eye dress after tarsorrhaphy suture has been placed. Now post-operative care. Regarding post-operative care, every dog operated should wear this Elizabeth collar, e-collar. This is an e-collar to prevent from self-mutilation. Otherwise, what will happen? They will destroy the eye. They will, because some kind of irritation is there, and owner should be advised to avoid excitement. They should, the very next day the dog will start looking and start getting vision, and the owner will be excited, and okay, he will start playing with the dog. Don't let him do all these things, and tell him to minimize the excitement. And then the eye should be regularly cleaned up with lukewarm distilled water for 7 days. And again, antibiotic, anti-inflammatory drops are being administered, and this tablet acetazolamide 250 mg, this should be given at the rate of 10 mg per kg in 2 divided doses for 7 days. This will check the intraocular pressure. It will not let the intraocular pressure increase. And we also use atropine or homeatropine drops for 3 days, first 3 days. So mydriasis will be maintained, so that it will facilitate the lens to get it, set it inside the capsular bag. And then antibiotic and anti-inflammatory eye drops are being administered. And the frequency should be tapered down and stopped after 1 month. So this is the post-operative day 1. So you see that in most of the cases, you will see this mild corneal opacity will be there. That was what I was telling you that the endothelium cell layer, in the morning also I tell that the endothelial cell layer count is very important. These dogs are usually more than 8 to 9 years, and we are not aware about the condition of the endothelium of these dogs. And if we do pachymetry, lens thickness, and fluorometry, then we will come to know that yes, what is the thickness of the cell count, what is the cell count of this endothelial layer. Then mild opacity is seen on day 1, and on day 3 this mild opacity will disappear, and you can see this clear cornea with positive PLR. PLR has been started responding to the light, and you can appreciate this, that this is the pre-operative pic of the same dog, and this is the post-operative. This eye is still having cataractous lens, and this eye is clear, and this dog gained vision the very third day. The owner reported that yes, this has started. And again one more picture of Lebra showing the both the cataractous eyes, and here you can see the difference between the appearance of cataractous eye and the intraocular lens implanted eye. So what could be the perioperative complications? Perioperative, as I told you, chemosis could be there, inflammation of the bulbar conjunctiva that will put problem to you while performing surgery, and meiosis could be there. Meiosis means as soon as you introduce the phaco probe into the eye, and if by accident it touches the iris or even not, then also meiosis could be there. There will be constriction of the pupil, and a very little space will be left over to you for conducting the surgery. So this is also a complication, perioperative complication. And regarding post-operative complication that are encountered in phaco, after phaco surgery, are glaucoma, then posterior capsular opacity can also be recorded, and corneal edema. If the endothelial cell layer is completely gone, then there will be permanent corneal edema, and now your case is gone. And hyphema, if there is little contact with the iris, then blood in the anterior chamber. Then again corneal thermal injury. This is something that you can avoid. The sleeve that we are using over to the needle prevents this kind of thermal injury, but this is by accident that the tip of the needle, naked needle, touched this corneal wound, and this causes the thermal injury. And again uveitis can be seen after, in some cases uveitis can be seen if this is particularly in cases where the pre-operative diagnostic procedure, we lack something in that procedure. Then what could be the challenges of cataract surgery in dogs? That the most important challenge is that the stage at which referral is sought. Particularly you see that dogs are brought to you for cataract surgery after a long time. When they become chronic, when immature become mature, and even hypermature, and develop some kind of complications, at that time they are bringing for phacoemulsification. So they should be reported earlier, and intense and pre and post operative inflammatory responses, because the dog is not with you, and the attendant or the pet owner might not observe the changes, and you might not be so frequently visiting, or the dog may be presented to you for post-operative examination. That is also a problem. And owner often do not bring their pets to the ophthalmologist until the signs of that's what we discuss in point number 1, that late stage of referral. And many dog owners, they do not go for surgery looking at the financial status. As I told you that initially we were putting this intraocular lens free of cost, and as we start charging, because we finished that project and now we don't have that much money to procure those lenses free of cost, then owner has to bear that cost, and many owners will refuse that. Okay, we are not going to buy that lens, and either leave the eye aphakic, or they don't go for cataract surgery. And many complications, this is not. And what are the limitations? Veterinary ophthalmologist, the most important limitation is that the learning curve. it takes a lot of time to learn the phacoemulsification, to expertise the phacoemulsification. And second is that the meiotic people which refuses to dilate in many dogs, that people do not dilate, and very hard nucleus and lack of jonular support. These are some limitations, and some dogs are having sunken eyes, deep set eyes. This is, or shallow anterior chamber, or hazy cornea, non-dilating pupil, or these many kinds of cataract. These are some limitations that a phacosurgeon feel while performing the phacoemulsification. And again, dog needs expectations may be simple, but a clarity of and improved quality of life for cataract surgery. You know, the dog may not tell you, but the owner will certainly give you regard if you perform a successful cataract surgery. Thank you, sir. I think we have taken much of time, and now the lecture is open for discussion. I'm ready to answer all your questions.
Thank you, Dr. Suresh.
Thank you very much, sir.
Yeah, Chairman, please.
Question. So, thank you very much, sir. Such a nice presentation. Now, some queries are there from the participant.
Sure,
so
sir.
they have read one by one.
Yeah.
Please.
Sir, myself Nikul Patel, MSc scholar. Sir, I have one query, sir. How to choose intraocular lens individual for individual patient?
Pardon? How to
choose intraocular lens for the different animals?
You are talking about the diopter of diopter?
Yes, sir.
Okay, doctor. Look, in most of the cases, actually, the universal studies have been conducted, and we are not performing keratometry. Okay, so if you are having facilities, if you want to exactly ascertain the diopter for a particular dog, then you have to perform keratometry. Keratometry can be performed with the help of ultrasonography or the keratometers, readily available keratometers. You know, in human beings, when anybody approach for cataract surgery, they just first calculate the size of diopter of the lens that is to be implanted. But here in our study for cataracts, a 40 to 41 diopter lens is universally accepted that, okay, in an adult dog, you just put 40 to 41 diopter lens and that will sufficiently work. So it is universally accepted that you can use a 40 to 41 diopter, and more, if you want to go for more precise, then you go for keratometry.
Thank you, sir. Sir, I have one more query, sir. For phacomorphic glaucoma, which technique is better, LCC or phacoemulsification?
For cataract with glaucoma?
Yes, sir.
Look, doctor, in case of glaucoma, I will suggest that either you should first, before going for any kind of procedure, cataract procedure, you should always check to try to treat glaucoma. First, try to treat glaucoma, try to reduce the intraocular pressure. Otherwise, what will happen, as soon as you open up the anterior chamber, there might be many complications. So in glaucomatous eyes, usually we delay a phacoemulsification or ECC. We first treat that eye and try to keep the intraocular pressure in normal level, and after that we go for surgery. So this is the matter of choice. You can opt for both, but in cases of glaucoma particularly, I say that you first treat glaucoma and then go for surgery.
Okay, thank you, sir.
Online query is there?
Sir, there are some questions asked by participant in chat box.
Please speak loud, sir, please.
Sir, participant asked.
Yeah, please.
Is there any necessity to maintain intraocular pressure during cataract surgery?
Pardon? Is there?
Is there necessity to maintain intraocular pressure during cataract surgery?
Maintain intraocular pressure during cataract surgery.
During cataract surgery.
Actually, intraocular pressure in case of phacoemulsification, you can't. We don't call that intraocular pressure, but we call that to maintain the anterior chamber. That is important, because as soon as you puncture the anterior chamber, you may go through the cornea and puncture the anterior chamber, the aqueous will be out, and the no doubt that pressure will be decreasing, but that ultimately we are not concerned with the pressure. That pressure is doesn't that causes harm. Actually, the problem is that if the anterior chamber density, space between the cornea and your instrument becomes less, then there will be damage to the endothelium. So we are afraid of injury to the endothelium rather than the intraocular pressure.
Dr. Disha Patel asked that which type of intraocular lens should be used, hepatic material or optic material?
Oh, what hepatic haptics? You are haptic or optics?
Yes.
Haptics.
No. Listen, the material lens. If we are talking about the lens material, material means optics and haptics. Both are made of different materials. The material haptics does not matter much, but it is the optics that matters. Foldable or rigid. It could be foldable or rigid, and both type of lens can be used, be it foldable or be it rigid. And particularly, if they are rigid lenses, they need more space to be introduced, to be implanted intraocularly. And in case of flexible, it is very easy to inject them through the intraocular lens injector. So I always prefer that foldable lenses should be used.
Dr. Binis asked that when exactly can we expect the vision to return if surgery goes well?
On the very next day. On the very next day, or even I say, as soon as, if you do not put tarsorrhaphy sutures to the dog, as soon as dog will recover, he will have vision. In case of phaco, as soon as he will have vision, slight vision, same as in the human being. You see, as we are, as a human being is being operated for cataract surgery, at the table, on the operative table, the doctor will ask, okay, can you see? Yes, you can see this light. Yes, you can see this light. So if the dog can speak, he will say, okay, doctor, I am very happy. I can see you. I can see the operating microscope. I can see your instruments. But it is a dog. He cannot speak, and we have to put the tarsorrhaphy sutures. So at that day, you cannot judge the vision. But on the very next day, when you will examine the dog, you will see that the little vision is there in the dog. And even you can test that by obstacle course test on the very next day.
Dr. Mukesh Patil asked that if there is a damage to endothelium, then what are the complications?
The most important complication is opacity. Very simple. The endothelium, the cornea will become opaque, and this opacity is from endothelium side, not from epithelium. So this will completely damage the cornea, endothelial layer.
Dr. Binis asked that what should we do? What should we do if some iridial bleeding is taking place? Bleeding
During during phacoemulsification procedure. Look, doctor, during phacoemulsification, we are using adrenaline 1:10,000 composition for checking the intraoperative bleeding, slight bleeding if there is. And if many times you see, even if adrenaline is not working and you have damaged the iris, many times it happens, then don't bother. It's my personal experience that in such cases, when there is severe bleeding and the eye is full of blood, then it depends whether the bleeding is after you have completed your surgery or it is before surgery. If it is before surgery or during surgery and you have not completed your procedure and you cannot check the bleeding, if bleeding is severe, then better suture it back. No surgery is possible. And if it is after surgery, you have performed all the procedures, and then if bleeding occurs, you don't bother. You just try to suture it back and then start many drugs like peptidase, and after after 7 to 10 days, that blood clots will be resolved and the eye will become clear. Until unless you have damage to the endothelium, there will be no opacity, and little hyphema might be there, but the eye will look near about normally, so that can be absorbed. You don't bother, but it happens rarely when in the initial stages. The bleeding happens in initial stages when you are not expert enough.
Dr. Binish asked it, sir, what to do if lens falls into the posterior chamber after placing it?
If the lens
placing after lens falls into posterior chamber after placing it.
Yes, this happens when you are not expert in initial stages, when you have posterior, it will sink into the posterior chamber only in condition when you have ruptured the posterior lens capsule. You have teared it up, then it will sink. Otherwise, there are no chances of sinking of the lens. Yes, during surgery, it happens in the initial stages of your practice. Then you cannot do anything. It is very tough to retrieve that lens because the complete vitreous and retina will be damaged. So better leave it as it. And I don't think like that as in human beings they are practicing that they can do vitrectomy and bring that lens back. In veterinary practice, it is a tough, tedious job. Yes, if you are expert enough, you can bring that back.
Dr. Gautam Solanki asked it, in extracapsular cataract extraction technique, vision of dog return after how many days?
Yes, actually, this question is related for both FACO and ECC. And as I answered that in FACO, very next day vision will be there. But in ECC, you see that the incision is very big and you have put sutures. So on the very next day, there will be corneal opacity at the site of incision, and that will moves little ahead towards the center, towards the pupil. And if it obstructs the pupil, even if the dog is able to see, vision has returned, but until unless it takes about 7 to 10 days, even up to 15 days to clear up that corneal opacity, and after that vision will be all well.
Okay, sir. Thank you, doctor.
Welcome, sir.
Okay, so I think no more question. Again, thank you very much, sir.
Thank you, sir.
Such a wonderful lecture. And
thank you, sir, for giving me this opportunity.
Thank you, sir. We hope in future we again see you.
Sure, sir, it will be my pleasure.
We have already proposed a vocational training in 2021 and so we will try for physical appearance of
it will be my pleasure, sir. I'm feeling warmth of your welcome and your gesture during 2019 visit, and the gesture shown by your faculty, and that time also you give me an opportunity to deliver the offline lecture. So that was a wonderful experience for me, and to perform the cataract surgery at your site. You are having such wonderful instruments, at operating microscope and chakshu, phaco machine, wonderful machine, sir. And you people are doing a wonderful job. Dr. T.K. Gehlot was telling me that you started doing this cataract surgery wonderfully, and I wish you a very good luck. And I wish that your students will be well versed in performing cataract surgery and give name and fame to your institute. Thank you very much, sir.
Thank you, doctor.
Thank you, sir. Thank you.
we'll end the session here. Thank you, all the participants, students, and all the committee members. Thank you very much.
Thank you.
So tomorrow again, the fourth day. So all the participants have to join 10 to 15 minutes before the lecture for the tomorrow. Thank you.
Thank you, sir.